What do we really know about recovery? How many libraries could we fill if we just put the scientific knowledge base of recovery? What do you think the odds are of their recovery in this environment? So some people said people need recovery conducive educational settings. That the future of addiction treatment and recovery hinges on whether we are successful at that transformation. And that vote isn't in yet. Are you with me? It is a pleasure to be here today. My name is Bill White. I am a senior research consultant at an organization called Chestnut Health Systems. Most of their treatment services are in the state of Illinois. I started the research division of that organization in 1986. We have about 90 full-time staff in the research division now, and all we do is study treatment outcome. And we've been doing that since 1986. So we do these long-term follow-up studies of tracking people 5, 10. We've got actually a cohort of people I will describe to you today. We're actually 13 years out in terms of our follow-up studies. So we're actually beginning for the first time to construct a science-based understanding of what happens with long-term recovery and what happens when people leave addiction treatment. Not in the first 90 days or the first 6 months, but really what happens to their life over time. And we're going to illustrate that quite a bit. I'm going to wear a lot of hats today. I'm going to, at times, sound like a country preacher, and when I do, I'm speaking as a recovery advocate and a person in long-term recovery. There are times I'm going to sound like a stuffy researcher, and I'm going to be flashing graphs and numbers at you. And that's when I'm going to have my sort of research scientist hat on, particularly as a person who studies recovery from the standpoint of science. I'm also going to talk about a person who's had wonderful opportunities to work with pioneer sites that are trying to fundamentally redesign addiction treatment in the United States. I've done a lot of work in the state of Connecticut, done a lot of work in the city of Philadelphia, and you're going to hear more about Philadelphia tomorrow when Dr. Achara speaks about the work we have done together there, transforming their behavioral health care systems in that city. So we're going to do a lot of roles. We're going to try to do two major things by way of my day today. And I want to distinguish a little bit about what we're doing today as opposed to how we will kind of shift gears tomorrow. What we're going to do today is give you a kind of crash course this morning in sort of the big picture of what's unfolding out there in the world of addiction treatment and recovery. What is this so-called recovery revolution? What is this recovery thing about? What is recovery management? What do you mean recovery-oriented systems of care? We've always been recovery-focused, right? And we hear some of that a lot. We're going to try to give you kind of some of the nuts and bolts that led up to what by the end of the day, I assure you, you will understand, is a fundamental transformation of addiction treatment as we have known it in the United States. As a historian, I'm going to suggest to you that the future of addiction treatment and recovery hinges on whether we are successful at that transformation. And that vote isn't in yet. Are you with me? Because what I want to tell you as a historian of this field is the acute care model of addiction treatment in the United States, as we have evolved it over 40 years, is politically and scientifically not sustainable. Did everybody hear me? As a cultural institution, addiction treatment is on probation. We simply became an alternative to the revolving doors of jails and drunk tanks and emergency rooms of general hospitals. And we promised them we would end that revolving door. And we had great promises of what we would do by way of recovery. And we have done some amazing things, agreed? We have people whose lives have been absolutely transformed through this thing we call addiction treatment. We have people who don't have enough words in their language to express the gratitude of what addiction treatment has meant for them and their families. But we are going to do, particularly early this afternoon, a fearless and searching moral inventory of addiction treatment as a system of care, looking at performance data. And what I'm going to tell you is with that performance data, compared to what we promised the community in this country we can do with addiction treatment, the gap is so great, it is unsustainable. How long do you think it will be, or are we already at a point where almost everyone in this country knows someone for whom addiction treatment did not work? What do you think a family who's about to readmit their addicted family member for the 5th time feels when they hear the slogan, treatment works? What do you think a family hears when they hear the slogan, treatment works, who buried their child from an overdose after 4 very expensive episodes of what they were told was the best addiction treatment in the country? We're going to talk about addiction treatment works. It has effects. But what we're going to talk about is this simple point. We are putting people in interventions in the United States whose problem severity and complexity is so great, whose recovery capital is so low, we're putting them in interventions so brief, so weak, it has little probability of success. And when they fail, what do we do with them? We punish them because we say he or she had their chance. As family members, we divorce them. We extrude them from our households. We send them to prison. We fire them from our places of employment. We take their babies from them because they had their chance. And what I'm going to argue with you throughout the day is that was not a chance. That was a setup. That was not a personal failure. That was a systems failure. Are you with me? Okay, let's get going. Thank you. We're going to begin big picture start. We're going to begin to ask, why do we need a revolution in the design of addiction treatment? And where is this so-called revolution coming from? I'm going to introduce this shift, what I'm going to call a fundamental paradigm shift from a pathology knowledge base as the center of our field. And we know a lot about addiction. Can we just acknowledge that? I mean, we know a lot about it. We can fill library after library with what we know about addiction. And we've learned a lot about this thing we call treatment over the past 40 years. But here's an interesting question. From the standpoint of science, what do we really know about recovery? How many libraries could we fill if we just put the scientific knowledge base of recovery? In 1998, I was going into Texas Dallas to do a conference not unlike this on another subject. I volunteer my time for recovery advocacy organizations when I travel. So the night before, I'd come in early to do a presentation for the recovery community. But in the afternoon, I was interviewing some old-timers about the early history of AA and NA in the Southwest. And I'm talking about like the 40s and 50s old-timers. I'm talking about the person that I was interviewing was 94 years old. Okay, 54 years of continuous sobriety in the fellowship of AA. So he and 3 or 4 other old-timers are sitting around, and we did this wonderful interview about the early treatment institutions like Mrs. Pink's Place, these early exotic drying out places that alkies used when things got really bad. So we took a break in the meeting, and Circe, the old-timer, now you got to remember, 54 years, he's 94 years old at this point. Circe says to me, Bill, what is this research stuff you do? So I said, well, seriously, I work with this team of people, and we follow people after treatment to find out what happens, to evaluate how effective treatment is. And I said, I'm really excited because we just got funded to follow 1,300 people for 5 years. Now I'm talking about a man with 54 years of recovery. And Circe looks at me and says, 5 years, very impressive. Right? And then he looks at me and he says, what does your research tell you about characters like us? And he kind of waved his arms at these other old-timers in front of me. And what do you think I had to say? We don't even know you exist. What do we know from the standpoint of science? We can tell you in the state of Georgia, to the decimal point, how attitudes and perceptions and behaviors of 8th graders, 10th graders, and 12th graders and household adults change in their perceptions of cannabis in the past 12 months. Agreed? And I can tell you that data going all the way back into the 1970s with the National Household Survey and monitoring the future studies. We have amazing knowledge about the subtlest of shifts in drug consumption and drug dependency rates. So tell me, do we have more people in recovery in Georgia today than we had last year? Who knows? Do we have more men than women in recovery? Are styles of recovery different when you go into different ethnic communities? I'm going to tell you later that we have religious and spiritual and secular pathways of long-term recovery. In the state of Georgia, what percentage of people who are in recovery from a religious or faith-based orientation to their recovery versus a spiritual orientation versus a secular orientation? You can't tell me that. And nobody in this country can tell me that. David and I are at a generation where we've been around a while. And one of the heartbreaking things we sometimes experience is people with long-term recovery, relapsing. You understand? I'm talking about relapse after 10, 15, 20 years or more. Now, I got stories I can tell you. I can tell you stories about physical problems as people age and pain medications that got them in trouble and then triggered relapse. I can talk about what happens when somebody's wife or husband dies 25 years into their recovery, or the death of a child. I mean, I got some thoughts about that, but what do I know from the standpoint of science about people in late stage recovery who relapse? Zip. We know absolutely nothing. How many of you here, by a show of hands, have a little bit of alcohol and drug problems in your family history? This is not a random sample of the population here, agreed? Now, here's what we know. From the standpoint of science, we can tell you, when we look at those 3 and 4 generation family diagrams, and we see those alcohol and drug problems hopping and skipping or coming through every generation, what do we know about our children? From the moment of conception, we know your children have increased risk of alcohol and other drug problems. Agreed? That's a given, flat out. We know that. So tell me, answer me this question. If I have a family tree like that, and Lord knows I do, does my recovery status have any influence on my daughter's resistance to alcohol and other drug problems, in spite of the risks she may bring biologically? Are you with me? Or if she should develop such a problem, does she have a better prognosis of recovery because I and other members of my family found stable recovery? And you know what? We don't have a clue. I mean, some of the most critically important things. How many of you known families that absorbed every insult addiction had to offer, and as sick as they may have been, hung together as families? They were still a family unit until recovery came along. Right? And guess what happened to this marriage in the first 3 years of recovery? Disintegrated into ashes. Do we know anything from the standpoint of science about how do we protect the fragility of families who've survived so much but haven't learned how to survive recovery yet? From the standpoint of science, we don't know that. So we're having this shift. When I left Searcy in Dallas, Texas in 1998, I had a kind of epiphany on an airplane. And here was my epiphany. My epiphany was, I spent my whole adult life studying the problem. And I know a lot about the problem. But you know, I don't know a lot about the solution. From the standpoint of science, I don't know a lot about the solution. And so that night on that airplane, I said, whatever time I got left in this field, I ain't studying the problem no more. I know enough about the problem. I'm going to devote my life and the life of my research institute to studying the solution to alcohol and other drug problems. Do you understand what I mean when I'm talking about a shift? A shift from a focus on the pathology of addiction, a shift in focus from the treatment of addiction to a shift to long-term solutions to very severe and complex alcohol and drug problems. We have a recovery revolution going on, and let me tell you what set it in place. The first thing was we began to see explosive growth of recovery communities around the United States and around the world. Everybody with me? Growth. Growth in the numbers of groups. Growth in the numbers of members. Growth in the diversity of those groups. If you haven't gone to Faces and Voices of Recovery's website and looked at their directory of recovery mutual aid that we update every 30 days, you should look at it. You will be stunned by the sheer number of formal addiction recovery support groups in the United States and the philosophical diversity represented by all of those different groups. We're seeing a growth of recovery community institutions very unlike anything we've seen before. The history of recovery is very old in the United States. We have organized recovery mutual aid societies dating to the 1730s in Native American communities. In Anglo community, larger community, we date from the Washingtonians of the 1840s, the reform clubs, fraternal temperance societies into the early 20th century. We have groups like the United Order of Ex-Boozers, one of my personal favorites. And we go on and on. We have a large number of pre-AA recovery alcoholic mutual aid societies. We've had an explosion of AA and NA alternatives since the birth of those fellowships. Musty, old, going way back. Treatment goes all the way back to the 1850s in the United States in terms of institutional treatment. We had an elaborate network of inebriate homes and asylums in the 1800s that collapsed and disintegrated in the opening of the 20th century. By the way, does that tell us anything? Does it tell us anything that a national network of addiction treatment institutions existed and flourished for over 40 years? Projected their future as very, very bright in the late 1890s. And within 20 years, they were virtually gone from the face of this country. We cannot take anything for granted. Are you with me? We cannot take anything that exists today for granted because it existed before and disappeared. If we want this, if we feel our communities need this, we must fight for it. There is no guarantee that what we have will automatically sustain itself. But we're getting a different kind of institution, different than mutual aid, different than treatment. We're beginning to get grassroots recovery community organizations like Recovery Consultants of Atlanta that is not an AA or NA organization. It's not a treatment organization. It's something kind of in between. Recovering people and their families and their friends and allies, culturally and politically awakening, coming together to begin to advocate for their common needs and to also develop indigenous recovery supports for long-term recovery that now do not exist in most communities. We are seeing the development. Let me give you a couple examples of these. We're seeing recovery homes grow prolifically in the United States. Invisibly, not part of the treatment system, not part of AA and NA. In the city of Philadelphia, we just finished a survey of recovery homes. We have about 30-some recovery homes that are actually funded in Philadelphia, mostly for forensic or criminal justice populations. But there are more than 250 recovery homes in the city of Philadelphia, most of which do not see one public dollar. No governmental funds, no private insurance funds, and yet we have this new institution inside the recovery community organized by and for people in recovery. But what happens if you're in that home, you've had aspirations, your school plans got destroyed or diverted because of your addiction, and you want to return to school? If somebody called you as an expert with an 18-year-old child that was now 6 months into recovery, and the parents said, because you're in the field, I want to ask you a question. I got a son or daughter early in recovery. They're ready to head off to a college and university. Do you have a recommendation for me? Because in research, we call these abstinence hostile environments. What are the prospects of somebody with 5 or 6 months of recovery landing on a college campus in the United States? I would suggest not good. What do you think the prospects are of an adolescent who goes through 90 days of inpatient rehab 4 states away and comes back and 24 hours after they're back home re-enters the public high school? What do you think the odds are of their recovery in this environment? They will be devoured. And the speed at which that occurs is terrifying. So, some people said people need recovery-conducive educational settings. So wouldn't it be neat if we actually created a recovery program on a college or university campus? Or maybe we should organize a recovery high school as an alternative school within a city like Atlanta. And you know what we've learned by those? Very high sobriety rates. And not only that, what do you think we've learned about academic achievement of these? I've studied 2. The most recent one was at Texas Tech University, the recovery program on the campus of Lubbock. The students who are there in recovery on scholarship, hear me, because of their recovery status. And you know where the scholarships came from? From the recovery community and also families who had lost a child to addiction and devoted some of their financial resources to help another child survive in stable recovery. So they endow these scholarships and bring people in recovery back to college campuses. Those students have a grade point average a full point higher than the student average of that university. I went to an open 12-step meeting on a Wednesday night on a campus. There are more than 200 students at this meeting. And I know there are only 45 or 50 students in the recovery program. I said, where are all these people coming from? You know what they told me? You know, some of us believe addiction is contagious. I believe that. I believe addiction is socially infectious, right? It can spread people to people. What we're also learning is recovery is also contagious. Because what we learned in Texas Tech is 1 student a week from the larger campus enters recovery based on their contact with this core of recovering students we have on this campus. Is that an incredible story? Recovery homes, recovery schools, but I don't have a place to work. I may be 35 years old and never have a legitimate employment, never paid Social Security, never drew a paycheck. I may have advanced training and background in sales, but nothing I can put on my resume, right? So how do I transfer that world? I mean, what am I supposed to do in recovery? How do I support myself in recovery? We need recovery-conducive places of employment, particularly for people at the earliest stages. How about recovery-conducive places for employment for people coming back from prison, re-entering the life of our communities? So we're now getting places like recovery at work in the city of Atlanta, right? Where people in recovery with that kind of history can come in and work under the supervision of other people in recovery and learn some things about mainstream employment and work habits and drawing a paycheck and getting a checking account and all that kind of stuff. If we go back not very far, 15 years ago, let's go back to the mid-1980s even. We got a cocaine epidemic raging in urban areas of the United States, devastating African American communities in particular. We got an AIDS epidemic that is roaring and devastating poor communities of color. How many churches had their doors open in 1985 welcoming crack cocaine addicted people with HIV into their congregations? Very few. And today, many of those same churches have vibrant, hear me, vibrant recovery ministries who not only welcome people when they knock on the door, they go get them. Aggressive outreach programs to bring wounded people from within their community into the fellowship of that church. Elaborate, faith-based frameworks of long-term recovery. Do you think part Part of the political and cultural, if you think of social movements, if you think of the civil rights movement, if you think of the women's movement in the United States, when those movements blossomed, did we see whole new social institutions created? Whole new organizations? NAACP had existed for what seemed like forever, back in the early 1900s. I think it was 1905. And that was about it. And all of a sudden we're hearing about what? We're hearing about SNCC, we're hearing about CORE, and on and on. We began to get this explosions of civil rights organizations as that community came alive. And we saw the same thing in the women's movement. We saw shifts in language, right? We saw shifts in how people dressed and how they looked and the names they would allow and not allow be applied to them, right? Are we seeing that kind of political and cultural awakening inside the culture of recovery in the United States right now as we speak? We are seeing that kind of parallel cultural development where cultures of recovery are developing their own language and values and rituals, and they're using art and they're using music, all of these to promote recovery. What's fundamentally different about this is what before we always had were individual communities of recovery who basically were in competition and conflict with one another, right? So if there were any early alternatives to AA or NA, they spent half their time criticizing AA and NA, right? Before you could ever figure out, well, you told me what's bad about AA. What are you? I mean, what do you offer? I haven't heard a thing about that. Yet today what we have are all those same people. Did you ever think you could see a day where you would see thousands of people in recovery marching? AA members marching next to NA members, marching next to Women for Sobriety and Secular Organization for Sobriety and Life Ring Secular Recovery, marching next to, God forbid, people in medication-assisted recovery on methadone. All under the banner that says we are not marching as AA members, we're not marching as NA members, we're not marching as Women for Sobriety, we are marching as people in long-term recovery from addiction. That's what this movement is about, fundamentally different. Now let's talk about what that movement's doing. And I'll give you some images over here in just a second. We have some emerging science coming on this. And as we proceed through, let me just take a very quick break to tell you about notes, because you've got all the slides. Everything that I'm going to talk about today is written in excruciating detail. Are you with me? About half of you got this book in your packet. The other half will get it when the other box arrives today or tomorrow morning. Okay? Because there's just a whole lot more of you showed up than we thought might. So, and we're very excited about that. So you're going to get that. So the kind of Recovery Management 101 that I'm going through today, right here, all written. Take it home and in your spare time, read it. We also have a monograph we did on how do we link people coming out of addiction treatment to this growing diversity of communities of recovery in America. That monograph is completed, all available free for download. We'll give you an opportunity. Lynette and them, they'll talk tomorrow about where to access those. We're going to talk about how places have transformed who are involved in a recovery transformation process. We have another monograph where we interviewed all these leaders about how do you do that process. And all those interviews are available, again, free for download. Part of what I'm going to be doing, particularly this afternoon, is I'm going to run a lot of data at you and a lot of studies at you. I don't want anybody in this room to say, well, that's an interesting idea, but I don't know that there's any science that supports it. More than 600 scientific citations that basically lay out the scientific rationale for a redesign of addiction treatment called Recovery Management and Recovery-Oriented Systems of Care, Scientific Rationale and Promising Practices. We just, hot off the press, have a brand new monograph that's everything you ever wanted to know and didn't want to know about peer-based recovery support services. Its history, its theory, its science, and some of the pilots that are going on around the United States in terms of peer-based recovery support services in the addiction arena. Now, as part of that, and particularly this last one, we reviewed all the scientific studies that said, do recovery centers Do recovery clubs, do recovery cafes, do recovery employment sites, do recovery homes make a difference in terms of long-term recovery outcomes? Do they reduce relapse? Do they increase long-term recovery rates? Do they enhance the quality of life of individuals and families in long-term recovery? We have the beginnings of those studies that we've summarized in the monograph. The evidence to date is an overwhelming yes. And the place in particular, because we've had the most studies done on those, is in the recovery homes. Let me give you the difference. How many of you know people who recycle multiple times through treatment? And they do treatment pretty good, right? No, I'm serious. I mean, they got treatment pretty well down at this point. They can give lectures actually better than the staff because they're more stable than the staff at this organization, given their turnover, right? My dear friend Don Koyas, who I'm going to show you a picture of in just a moment. Actually, let me just do that, and I'll come back and tell this story. Here's some images from the recovery advocacy movement in the United States. Buzz Aldrin, that we're all reading about this morning, right? Referenced this morning in terms of the incredible experience that he had, being one of the first people on the moon, later developed alcoholism, got in recovery. In 1976, Buzz Aldrin was one of 52 Americans, the first 52 Americans as a group that stepped forward and announced themselves in long-term recovery from alcoholism, sponsored by the National Council on Alcoholism. We had TV personalities, scientists, sports figures. It was an amazing day. 52 people. Last year we had 40,000 people, individuals and families, in long-term recovery, in recovery celebration events last September. Did everybody hear me? 40,000 people. You want to talk about a political and cultural awakening? What do you think it's like for some young person who's never known anybody in recovery, has lived he's at the tail end of 5 generations of devastation of addiction in his or her family tree, living in an environment where they've never known anybody in recovery. The first day they get carried to an event like this, and what they see is recovering people as far as the eyes can see, with their children. Are you with me? And with their partners and spouses. Families back together. Amazing, amazing stories coming out of these recovery celebration events. These are recovery advocates coming to Washington, D.C. to be trained as, for all practical purposes, sort of political lobbyists or advocates on very specific recovery-related social policy issues. We have posters that begin to confront people in recovery saying, by our silence we have let others define us. Do you agree with that? By our silence we have let others define us. We have created a world where judges only see those people who keep coming back to them. Where addiction counselors only see the clients that keep cycling back through again. And unless that counselor's in long-term recovery and is part of that recovery community, that counselor never sees the people in long-term recovery. How optimistic do you think that counselor is after about 5 years? Who sees the horrors of addiction every day coming through the front door and never sees the blessings of long-term recovery. And what this is about is to begin to recruit a vanguard of people in the United States to stand up and announce their presence in this culture as individuals and families in long-term recovery. We are the faces and voices of recovery, these kinds of campaigns. Let me go up one. These are particularly active, and what distinguishes these is this movement is very, very active in communities of color in the United States, particularly in African American and Native American communities. The person at the center of this sacred Wellbriety hoop, that's part of the Wellbriety movement across Native American tribes in North America, Don Koyas, here's how he describes addiction treatment. He said, what we do in addiction treatment is like what we would do if we had a sick and dying tree. We look at the tree, we try to do some things, and the tree just keeps getting sicker and sicker, and it's about dead. We dig it up out of the dirt, and we carry it way, way over here in some good soil, and dig our hole and put the tree in the hole, and we fertilize it, and we water it, give it lots of sun, talk to it every day, and what happens to that tree? Tree blossoms. We said the tree's well now. And we dig the tree up, and we come back over here. And then what? We're shocked. We're horrified that the tree now gets sick and dies again. That's a Native American metaphor for an acute care model of addiction treatment. What the Native American Wellbriety movement is saying is it's time we began to treat the soil in addition to the tree. Are you with me? So what we're talking about as we move through today, you're going to hear a shift in language. We're going to start shifting from talking about just treating individuals. We're going to be talking about treating families, treating neighborhoods. We're going to talk about treating communities and whole cultures. We're going to talk about the concept of community recovery in addition to individual recovery. Okay, let's move. Here's the advocacy vision. This is not the first advocacy movement. In 1944, Marty Mann was the first woman who had achieved sustained sobriety in Alcoholics Anonymous, had a vision. And her vision was to create an organization that would fundamentally change how this country viewed alcoholism and the alcoholic. And she created an organization called the National Committee for Education on Alcoholism. And it later became the National Council on Alcoholism, and it's the precursor of today's what? NCADD, National Council on Alcoholism and Drug Dependence. So from 1944 through the 40s, 50s, and 60s, Marty basically created all these local affiliates around the United States who mobilized around some core kinetic ideas. Ideas like alcoholism is a disease. Therefore, the alcoholic is a sick person. The alcoholic can be helped. The alcoholic is worthy of being helped. And alcoholism is a major public health problem and worthy of public funds to treat it. Those were the core ideas. The local affiliates tried to open local hospital doors for detoxification, created local alcoholism information centers, created, to the extent they could, little alcoholism treatment rehabilitation facilities. And they did that, very successfully. And this is the beginning of the modern treatment movement before we discovered federal dollars. And then 1970, that movement crested with the passage of legislation that began the flow of federal dollars to states and local communities to build, to staff, to operate alcoholism treatment facilities and evaluate those facilities. And within a year, we had the same thing going on with an organization called NIDA, right? This is the beginnings of NIDA and NIAAA at the federal level. So we had these incredible... Now here's the vision. The vision through the 40s, 50s, and 60s. The vision was of this large, ever-growing recovery community. That was the goal. But there was a recognition that some people are sicker than others. Some people, their problems are so severe, so complex, they have so few resources internally, so few social supports around them, they simply can't get inside this circle called recovery and stay there. So we need this thing called treatment to help them. And all these recovering people and their families lobbied for states and lobbied for the federal government to create the dollars to create this thing called treatment, which was going to be a portal of entry into recovery. And they did that for all of us. Now, some of those aging advocates come back at 2009 and look at the world, and what they see is a multi-billion-dollar treatment industry that looks at recovery as an afterthought. Are you with me? And what they're saying is somewhere along the line, two things happened. Addiction recovery became disconnected from this thing we call addiction treatment. And it's time we reconnected them. It's another way of saying we need to connect acute biopsychosocial stabilization within the framework of treatment to the much larger and more enduring process of long-term individual and family recovery. They also said, see if you think this is fair, too many treatment organizations lost contact, became isolated from the grassroots communities out of which they were born. They weren't programs anymore. In the 1980s, they became businesses. And it seems like they cared a lot more about bottom line and a lot more about margin than mission. And all of a sudden, we had addiction counselors, tenured addiction counselors. I would run into a conference in the late 1980s. I mean, I would go to conference in the late 1980s with counselors, and I needed to put Prozac in the drinking water. I'm telling you, that was a bad time. People were coming up and they would confess to me. They were leaving the field. And I'm saying, what do you mean leaving the field? You are the field. How can you leave the field? The kind of people I'm talking about? And I'll give you one example. This person that told me this, I said, I just couldn't even talk hardly. I said, what are you talking about? And he said, Bill, it's just getting harder and harder to feel good about what I'm doing. And he said, I feel like I'm in a world that cares more about if there's a progress note signed by the right colored ink as opposed to whether any of my clients are making progress. He said, I feel like we're becoming people processing institutions rather than people changing institutions. So I said, what are you going to do? He said, I found another way outside the field to support my family till I retire. But then here's the heavy part. I'm going to come back into the field and work as a volunteer because I think I'll have more of an impact on people's lives as a volunteer around recovery than I have. This is a full-time counselor. Does that scare anybody? That they say, I will be a more potent change agent as a volunteer than I will be as an addictions professional in a role of addiction counselor. That's scary. And that's what so all of a sudden, that's when people began to step back and say, somewhere in all of the wonderful things we've done, we lost something. There's some things very important we lost on the way to professionalization. We got to go back and get that. And this is part of this recovery advocacy movement. We are seeing, in terms of this paradigm shift, we are seeing a shift. We're seeing it in the mental health fields, beginning in the 1970s and 80s. A consumer survivor movement within mental health, a drive for recovery-oriented systems of care within the mental health arenas. We're now seeing that at the highest levels within the addictions arena. We're seeing CSAT pursuing recovery conferences and supporting all of our monographs on recovery-oriented systems of care. We have a night in NIAAA beginning to talk about the need to develop a recovery-focused research agenda. Are you with me? So we're seeing evidence of this shift that's coming. We're seeing calls for, we're seeing sort of a whole new language emerging. And if you haven't been part of that process, it sort of bumps into you and you think, what is that? My goal here in this first introductory module to really get us set for the details this afternoon of how is clinical practice going to change in this new world. I want to begin by talking about how this shift in paradigm is beginning to influence. These are 3 new resources we have, and I'm going to just step back and give you a little bit of something else that's impacting this drive towards recovery-oriented systems of care, and it really is science. When I came into the field in the late 1960s, I worked in the field in the early 1970s. Let me tell you one of my assumptions. My assumptions was that alcohol and drug problems, as I was seeing them in my residential treatment program and outpatient programs in those years, were the same problems existed in the community, it's just the ones out there hadn't got to me yet. Are you with me? So I was saying alcohol and drug problems in clinical populations are the same as in community populations. They just haven't got bad enough to get to me yet. So I assumed anything I learn about alcohol and drug problems and addiction working with my clinical populations is applicable to people out there in that other world. What I need to tell you, I was absolutely wrong. You everybody hear me? Absolutely wrong. Because most of us in those years operated on what might be called a single pathway model of addiction treatment and recovery. We said there's a single etiological agent for this thing we call alcoholism or chemical dependency. We call it an X factor. We don't know what it is, but we're about to discover it any second. And we said that every year for about 50 years. And if you got this bug, this is what it looks like. And if you look like this, you need to come into treatment that looks like this. And then you need to go out of the treatment, and this is how you need to live the rest of your life. One way in, one way out. Here's what the science began to tell us. There are multiple pathways into significant and severe alcohol and other drug problems. Everybody hear me? Multiple etiological pathways. Number two, those pathways unfold in some very different patterns. Patterns by way of how they first present, patterns in terms of whether they're acute or chronic, and in fact, under patterns, here's the big story. Alcohol and other drug problems present in transient and chronic forms. Everybody hear me? Transient, meaning that the onset, peak severity, and cessation of that problem occurs within a very short time span, generally 18 to 24 months. Let me give you an example. If I studied 1,000 couples going through a divorce event, what do you think happens to psychoactive drug consumption in the 24 months surrounding that event? Every psychoactive drug. What do you think happens to nicotine use, alcohol use, prescription drug use, illicit drug use? Goes up. Now here's the good news. The good news is if I come back 5 years later, I'm going to find some of those people are going to get in trouble, right? Didn't have a problem before the divorce, got into this 24-month window of vulnerability, got themselves in trouble. But if I take those who are in trouble in that window and I come back 5 years later, most of them are not in trouble. Meaning what? Including some of you in this room. Come on, be with me. All right, come on, right? Let's get real here for a minute. Because they got through it. They were wounded. They bled. They were pained. They found ways to get themselves supported. They healed. And as they healed, they began to shed those problems. If I come to the colleges and university in Georgia, how many students will meet DSM-4 criteria for abuse of alcohol? Right now, today. Well, let's be clear. It's pretty substantial and scary if you look at those numbers. They meet, I'm not talking about they binge, I'm not talking about binge drinking. I'm talking about they meet diagnostic criteria for a substance use disorder. Now, here's the good news. Most of them, what's going to happen when I take them out of the college environment? They're going to maintain that environmentally supported pattern of alcohol and drug use. But when I shift the environment, and they get families and jobs that are incongruent with that, they shed them. We call this maturing out or spontaneous remission or other such things. Here's the key. The vast majority of people with alcohol and other drug problems will solve those problems without professional treatment or participation in recovery mutual aid groups. And we should celebrate that and find ways to speed that process up. Here's the punchline for today. Some of these pathways don't do that. So what's the difference between clinical populations and community populations? Because if we study all those folks out there, by the way, let's get right to the moment. How many people do you think were sort of on the bubble in terms of their alcohol use? Until suddenly, unexpectedly, they don't have a job in 2009. And don't have a career. They don't have a job in the place they were expecting to retire from in 10 years. Now, if I take 1,000 of those individuals, what do you think their psychoactive drug use looks like these days? So what can we expect? In the economic climate we're in, we're going to see a rise in alcohol-related problems in the midst of this kind of difficulty we're going through. Some of those individuals will rebound from that experience They'll retrain themselves, they'll find other occupations, and in 5 years later, it'll be nothing but a little blip in their life. And some of those people are going to be dying of addiction. Are you with me? So what's the difference between the two? Because here's the crucial point. If all these people get well without treatment, why do we need treatment? Right? I mean, if we have this huge maturing out natural recovery phenomena going on, is treatment dollars just a waste of time? Will those people eventually just get well on their own? Well, here's the problem. People that you and I see in treatment don't look anything like people who are out there experiencing natural recovery. And here's why. Higher personal vulnerability. I'm going to do the whole list, then I'm going to come back and do some of these. Higher personal vulnerability. I'm going to talk about family history. The second that I got a family history of alcohol and other drug problems, what's my prognosis of transient versus chronic problem? Chronic, right? I mean, I'm bringing some weight behind me, some intergenerational momentum that's going to tend to make this a prolonged problem rather than a brief problem. We're going to talk about lowered age of onset and some other things in a minute. The more severe that problem is, what? The greater the problem severity, the less the likelihood of natural recovery. Now, what if I give you multiple problems? I give you multiple drug choices. Oh, hell, let's just add injection drug use as part of that, okay? And then I add a co-occurring psychiatric illness. And then I add something like homelessness, chronic unemployment, a history of being a felon. Now, what's my prognosis in terms of chronicity? Yeah, if I got all those and you're waiting for me to mature out, you got a long damn wait. Okay, greater personal and environmental obstacles to recovery, lower recovery capital. Problem severity, breaking intergenerational cycles. Okay. Let's go to this one. If we're wanting to say, well, in terms of working with my clients, if I'm working in a private practice, and I have lots of different people coming in that I'm seeing with alcohol or drug problems, sort of within my caseload, which are those that I may need to think of in terms of this larger recovery management agenda, as opposed to the idea that I take care of anxiety and depression and other things that these other problems will kind of spontaneously remit. And here's part of it. The second I talk about low age of onset, what can I predict? This is the most historically significant drug trend of the 20th century. Lowered age of regular onset of unsupervised alcohol and other drug use by teens and preteens is the most clinically and socially significant because of this. The lower that age, the greater for the risk of an adult substance use disorder. Number two, the speed of problem development. What do we call it? Call it telescoping, meaning what? Those old classic progression charts that we used to say when the alcoholic begins drinking at 19 or 20. But I got a kid that's 9, 10, or 11 at onset. What can they look like? Can I have a kid physiologically in the latest stages of alcoholism at 17? Because what? If use began, now when use begins at 18, you got a while. I mean, an adult body can take a lot of punishment, but not a 9-year-old body. We're going to dramatically escalate problem severity and speed. Problem complexity, the lower the age of onset, what do I do to the risk of a co-occurring psychiatric problem as part of that? Extremely high. Treatment prognosis. Could I predict treatment prognosis simply based on age of onset in an adolescent treatment program? The earlier the age of onset, the higher the risk of post-treatment relapse. Because it's also a marker for inadequate family supervision and family support and a whole bunch of other things. Duration of addiction career, yeah, predicts long. What about mortality? We've actually got studies. We can predict which adolescents at 18 are most likely to kill you in a DUI-related crash based simply on age of onset. The lower the age of onset, what? Not only the higher the problem severity, but what about risk-taking, impulsivity, impaired judgment? And I combine all of those, and I have somebody that poses significant threats to public safety as an 18-year-old in an automobile. Let's do a couple of others here. Traumagenic factors. How many of you have really kind of come aware of the role of trauma in the lives of the individuals that you work with? And it's a complex relationship because trauma in and of itself does not predict an adult substance use disorder. Everybody hear me? I mean, you would think so because we see so much of it. But the fact is, when we do community surveys, we find a large number of people who experience trauma, who in their adult lives have no psychiatric illness, who in their adult lives have no substance use disorders. So the question is, what's the difference between the trauma of those we see in treatment and those in the community populations that are so resilient? The question is not, did you experience physical, sexual victimization or trauma in childhood? But these questions. How old were you when the victimization started? What do we know? Lower the age of onset, what? Potentially the greater the trajectory of developmental effects. How long did it last? Was this a moment in your life, a day in your life, a week, a month, a year, or in our clients, we often hear what? I mean, we hear these complex, horrific things spanning years. Was there a single perpetrator or multiple perpetrators over the course of your life? If there's a single perpetrator, I learn what? This is a person I cannot trust. I need to protect myself. I can't be alone with this person, etc., as a strategy. If there are multiple perpetrators in my life, what do I learn? There is no safety. Everybody's on the make. And eventually I may begin to think about what? Maybe it ain't them. Maybe it's something about me. What was the relationship of the perpetrator to the family? The second, it's a family member or someone whose presence was sanctioned by the family. The larger impact of trauma dramatically escalates as opposed to a stranger. Greater violations of trust. Types of abuse. Is all abuse the same? If an adult exposed their genitals to me for their sexual gratification when I was 8 years old, never touched me, that is sexual abuse by any definition of that term today. If that same person sodomized me at age 8, that's also sexual abuse by any definition of that term. Are these different experiences qualitatively? The more boundary invasive forms of trauma have what? We tend to see have much longer trajectory in terms of effects. Here's what we don't know in the trauma research. What about people who have all these traumagenic factors and are resilient? Who don't have addiction in their lives? Who don't spend their lives in and out of psychiatric hospitals in their adult life? Who don't have these horribly toxic, violent, abusive relationships? And the answer is, we don't know. We got case studies, but we don't have the same kind of science. So here's another area where we know a lot about the pathology. We're starting to figure it out. What we don't know is the story of recovery and resilience at this point in time. So there may be, if we have individuals who have these traumagenic factors and don't have those resiliency factors, what can we predict? Long addiction career. And not only in addition to those risk factors, they have low recovery capital. Important term for these 2 days. Recovery capital is the amount of internal and external assets, resources I can mobilize to not only initiate my recovery, but to sustain my recovery over time in a natural community environment. Now, if I got low to moderate problem severity, everybody with me? Low to moderate, I still meet diagnostic criteria, but there's a huge gap of severity inside those. And I'm on the low to moderate end, but I bring a lot of recovery capital with me. What's my prognosis for recovery? Really good, and it's really good, by the way, without treatment. In fact, guess who? I can give you the highest recovery rates in the history of research. Physicians. Addicted physicians. High pathology rates. High risk of addiction. High prevalence of co-occurring psychiatric illness in that population. High opiate use in that population. Fairly high injection drug use in that population among the opioid users within that subgroup. They have incredible access to powerful psychoactive drugs, right? So there should be a lot of things that would compromise their recovery outcomes. They have professional and family enablers all around them, right? To protect them until very late stages of addiction. So why in the hell do they have the best recovery rates in the country? What kind of recovery capital do physicians bring to their recovery that many of our clients do not? They bring status. They bring a career. They bring incredible levels of financial resources that can buy them, in some cases, the best treatment this country has to offer. What else? Internal resources. They also bring a medical society through a physician's health program that will monitor them for how long? A minimum of 5 years. So tell me, what percentage of your clients have 5 years of post-treatment monitoring and support? And I'm talking about at admission. I ain't talking about discharge now. I'm talking about if they're admitted, they get 5 years of post-treatment monitoring and support. What? 0? Okay, we're coming back to that question, believe me, later. Okay. We're going to take, this is the crash course on recovery. Recovery research. Some key points to underscore before we shift gears into this afternoon. The problem with studying recovery and research is you got to define it. So we say, okay, let's see. Recovery is sustained abstinence from the primary drug to which you met diagnostic criteria, right? So if I met diagnostic criteria for alcohol dependence, then recovery is what? Sustained abstinence from that drug choice. But then we got into problems. Because somebody said, well, I'm in recovery, but they're smoking reefer every day and binging on cocaine Friday through Sunday night. Talking about the joys of drug-free living. And we said, oh, no, that ain't recovery. So we said, okay, you got to abstain from your primary drug, but you also got to abstain from secondary drugs, except nicotine, and then you got to smoke 4 packs a day if you're in recovery. That's part of the cultural heritage of the recovery culture. So then we went to, well, what do we do with these people who met diagnostic criteria, and we come back and follow up, and they're still using, but they ain't got any problems in their life. And it's not just their bullshit. We're interviewing family and employers, and we simply can't find any clinical data here. It looks like we have somebody who has decelerated alcohol and drug use, meaning they once met diagnostic criteria for substance use disorder, but in the past 12 months, they haven't met that criteria. Now, some of you can predict, the longer we go on, the smaller that group gets. For example, we have people who can move into that decelerated pattern in a very stable point of their life, right? They've returned to alcohol or drug use. They're not experiencing inability to abstain or loss of control. Do pretty good for the first 18 months until now they go through a divorce. You got any predictions for me? Or now they lose their job. Or now their daughter is killed in an automobile accident. Then what do we got? Incredible risk of resumption, even though if that hadn't have happened, maybe this is a person who could have prolonged that. How many of you really buy the idea that recovery is more than the absence of alcohol or drug use in an otherwise unchanged life? Recovery is more than abstinence. You know, Bill Wilson talked about emotional sobriety. They coined the concept of dry drunk people who were abstinent but might as well be drunk, you know. The problem with addiction is some people can be assholes before they become addicts. So I got an addicted asshole, if you'll pardon my clinical language here, who then gets sober. And now what have I got? And all of a sudden we're saying, nah, that ain't exactly recovery. For those of you in the criminal justice system, let me tell you how important this is. I did one of the first follow-up studies I was involved in was about 1977. And we're doing calls on everybody admitted to a facility in its first 5 years of operation. And one of the names I drew, I grimaced when I saw the name. notorious character in treatment. In my community, notorious predator in terms of complex criminal career, hustler, phony. I mean, I had more pejorative language for this client than I almost need to go to confession and clean it up, you know. So I drew this name. And I knew what I was going to be hearing, all the jails and prisons. So I call, and guess what I hear? Oh, Billy, I got the mother on the phone. So nice to hear from you. Jamie's done so well since we came to your hospital. He's not had a drink, on and on and on. And he ain't been in any jails, and so I'm thinking, wow, I'm feeling pretty good about my treatment now, right? Because this is a tough client. But until I got to some of the social collateral, and let me tell you the conclusion. I have a man who's been alcohol or drug-free since the day he left my facility, by all the evidence I can collect. In his addiction years, he was heavily involved in the criminal justice system because alcohol and drugs so impaired him. He was like on those stupid criminal stories, you know? I mean, when he started drinking, he should just call and make an appointment with the police. He was going to jail. Well, now what I have, and I feared that one day in one of my lectures, a light bulb came on for him. And he said, my God, Bill's right. All I got to do is not drink, and I'll never go to jail again. So guess what I found 5 years later? I have an extremely competent criminal predator in my community who has maintained radical abstinence from alcohol and other drugs. Is that recovery? He's given all his probation and parole people clean urine straight through. And they're very pleased because he can charm the pants off of them. And he is incredibly competent as a criminal. So, did I serve my community in helping him get sober? Is this the recovery we would aspire to? No. All of a sudden we're saying, no, recovery's more than that. So we began to talk about this idea of remission plus. Not only do we have to have remission of the alcohol and other drug problem, we have to have some movement towards global health. And then, how many of you believe that some of us in our addiction years really wounded our communities? That when it comes to taking an inventory, it goes beyond individuals and families. How do I make amends to a community that I served as a street-level dealer in for 9 years before I got in recovery? I mean, how do you make amends for all the people that I individually wounded and to what I did with the community that I wounded through that process? You know, there's very few health conditions where we say, oh, by the way, to be well from diabetes, you got to be a good citizen. Because there ain't no nexus between citizenship and diabetes, agreed? Is there a relationship between citizenship and addiction? Given the nature of the disorder, given the frequency of predatory behavior that emerges out of late-stage addiction, yeah, I've got to clean that up. So we end up we're migrating towards, and it might be the next slide, this three-part definition that talks about sobriety, that talks about global health, measured how? Physical health, emotional health, spiritual health, what? Occupational, relational in terms of family, social supports, and some kind of life in the community. We even talk with some people about language like life, meaning, and purpose, although that'll differ dramatically from person to person. Types of recovery. We're beginning to talk about different types and styles. And all of this is in the monograph you have in the article called Varieties of Recovery Experience by Kurtz and myself. And we talked about, we have abstinence-based recovery, moderation, recovery resolution. There should not be any controversy related to this today. It is common sense. Yes, we have people who resolve alcohol and drug problems by decelerating the frequency and intensity of their use. Period. Now here's the key. Who are they? In terms of those vulnerability factors, they tend to be people without all those vulnerability factors. In terms of people with recovery capital, they tend to be what? People with lots of recovery capital. And in terms of problem severity, another key, they tend to be at low and moderate levels of problem severity. As soon as I add those other factors in, what happens to the probability of a moderated resolution? It's almost linear. As those problems increase, the probability of a moderated resolution really declines. And by the way, even people who successfully pull this off for a while often migrate towards abstinence. And when we interview them and say, why? Because we couldn't identify pain. We couldn't identify problems and consequences to their continued use. Why then did you shift to abstinence? And they said, it's just too damn much work. It's too hard. I mean, it's this incredible act of will. And it suddenly dawned on them, this is not normal drinking. I mean, normal drinkers don't sit around that preoccupied of having to measure every sip that's going into their body and say, I can't take the 5th sip because I'm past the 4th line. I mean, that's not normal. They just said it wasn't worth it. It was a whole lot easier just not to use. Medication-assisted recovery. We have a whole arena of new medications. We have aversive agents that go back to 1947-48. We got maintenance agents that go back to the mid-1960s through methadone and LAM. We got buprenorphine and probably a host of other drugs coming fairly quickly. And we've got anti-craving agents in the alcoholism world particularly. And because the issue's been raised, is this legitimate recovery? Are people who are on these drugs in recovery? We brought kind of like the statespeople from the addictions world, senior researchers, recovery advocates, and others together to wrestle pretty painfully with these questions. And I want to give you just one that's sort of the consensus. And I'm going to give it to you on the most controversial issue, and it has to do with methadone. The Betty Ford Institute consensus panel brought together senior scientists, recovery advocates, treatment specialists, family members, wrestling with this issue, and here was where they ended on their definition of recovery. Formerly opioid-dependent, primarily heroin-dependent individuals who take naltrexone, buprenorphine, and most importantly, methadone as prescribed, everybody here, as prescribed, and are abstinent from alcohol and other non-prescribed drugs would meet this definition of sobriety. Now, this does not automatically say that they would meet the other two, global health and citizenship. If I'm running a methadone filling station for profit, are you with me? You okay with this concept? We have places in the United States that are methadone filling stations. If I run that, I can get people who will meet this criteria in terms of metabolic stabilization. But if I haven't built in a recovery culture surrounding that medication, if I haven't linked these people to recovery communities, if I haven't begun to help these individuals build a meaningful life in the community, I ain't got recovery here by the Betty Ford definition, agreed? But here's the key point, controversy. But if I do have citizenship and I do have global health and a person on methadone, we're saying there are many paths to long-term recovery, and hear me clearly, all are cause for celebration. Now, I say that having been a person who in my own history comes out of therapeutic communities of the 1960s. So you can probably guess my early attitudes towards methadone. In fact, one of my mentors at University of Chicago, Dr. Ed Senay, one of our first encounters, the subject of methadone came up. And I went into one of my psychotic rants about methadone, coming straight out of the TC in those days, right? And here's this eminent psychiatrist who kind of eyes get big and open, and he kind of quiets and puts his arms up and waits for me to kind of wind down. And he looked at me and he said, "Young man, your passion is in inverse proportion to your knowledge." That was the beginning of my education. Okay, recovery prevalence. Here's the great news. When we study people who once met DSM-4 criteria for a substance use disorder, either abuse or dependence, and we come back and survey them in community surveys and say, did you meet this criteria for the past 12 months? And in some studies verify that with family members, in other studies we verify it through chemical drug testing. We find what? We find high rates of recovery. We find recovery in the 50, 60 percentile range. And I'm talking about all people who once met criteria. So what's the news is good. Long range, most of the people, over half, who once met criteria will not have met that criteria for the past 12 months. Now, hang on to that, because there's a problem with the 12 months I'm going to tell you about a little later. So what that forces us to do is think in these terms. We have individuals who've met full recovery by the Betty Ford three-part definition. Do we have other individuals that you've treated, that we know in our recovery fellowships, who will never get a 25-year chip, who will never get a 5-year chip? They have what we call, in the general world of medicine, or in the world of mental health, we would call this partial recovery. We've had a dramatic reduction in the frequency and intensity and consequences of the disorder. The disorder is still there and periodically rises. In many cases, with a structured program of recovery, they quickly rebound and re-enter. These are these people that keep coming in. They keep coming back and talking about a slip that they had. And they may do that for a long time before they get, some of them will get continuous sobriety, and some of them will never get continuous sobriety. But what's happened to the quality of their life based on 10 or 15 or 20 years in a fellowship? We've dramatically elevated. What have we done to the quality of their family life based on that? What about the damage to the community? Dramatically lowered based on that. We also have, this is the hidden story of recovery. I do not stay in the field of addiction treatment for 40 years because I love spending time with people days in recovery. I don't think people in days in recovery are particularly charming. Can I just be blunt on this? This is not the people I want to fill my life other than through my service work. But let's be very clear, when my service work is done, I ain't going to go hang with them. But what about people with 25 and 35 and 40 years? There's the hidden story. There aren't too many other conditions. Cancer, by the way, is one. How many of you know somebody with cancer where a confrontation with cancer virtually transformed who they were as a person in terms of the quality of their life and the clarity of their values, the kind of way they lived and interacted and the way they served, what they got into later. And then you hear them and you think they're nuts because they talk about, thank God for my cancer. Because my life was so shallow and so empty before I had that confrontation. And that really was the beginning of who I am today as a person. There are many people in long-term recovery who get better than well. And what I'm talking about by better than well is I'm describing that in terms of the quality of their health. I'm talking about the quality of their character and their values, and most importantly, the quality of their service to the larger community. They live incredibly exemplary lives. And these are some wonderful people to find and spend time in your life with. These are the people, by the way, who also shifted from addiction carriers, because some of those people were pretty charismatic in their addiction years as well. They're now recovery carriers. If you don't want to get recovery, you better stay away from these people. You hear me? Because you can catch it in spite of yourself if you get very close to them. And some of you know who some of those people are. Styles of recovery. How many of you believe there are, let's talk about styles of addiction for a second. How many of you believe there are people who initiate and sustain addiction and they don't have any contact with any other drug addicts? It's solo addiction, all by myself. I initiate it, I sustain it. I don't have any of that riffraff around me. Anybody come to mind? Physicians, the Michael Jacksons of the world can initiate and sustain long-term addictions without significant contact with a culture of addiction. And we call them it's an acultural style of addiction. They're not involved in the language and rituals of the life. Now, we got another group of people who are bicultural. These are people who can pass. They can mask their addiction because they can function very well in the mainstream society. And Friday night comes and they jump into the telephone booth and change clothes and come out the other side and go to the other life, right? In the cocaine years, you saw a lot of this. Right, a lot of them folks doing their Monday to Friday, but look out on Friday, Saturday. I mean, this was a whole, and they were deep in the life on the weekends. Bicultural, right? We also have people, and we see a lot of these in treatment, who were practically born in the culture of addiction. And some were literally born in the culture of addiction. grew up in the culture of addiction, don't know how to function outside a culture of addiction, don't even have the language skills that will allow them to deal with civilians or normies or earthlings, as they're sometimes referred to in recovery circles. What about those people? I'm going to tell you later, people who are culturally enmeshed, deeply enmeshed in addiction, may need an equally enmeshed culture of recovery to initiate and sustain recovery. That we need to not only treat the addiction inside them, we got to pull them out of this culture of addiction, and we got to enmesh them in a culture of recovery that meets all those same needs. Now, I can treat the intrapersonal stuff with Cassandra in an inpatient program. But if she's deeply involved in that culture, and I now hug her and give her a graduation chip, and she walks out the door to that culture, what are her odds if I have not given her another world? So when we shift to recovery management discussion this afternoon, the issue is going to be not just how do we open a pathway of recovery, how do we create a world some people can recover in? Are you with me? I'm talking about a physical, cultural world. What do you think the recovery fellowships have done for so many years? They are that culture. Now, let's talk about recovery. In the recovery culture, can I have a person who initiates and sustains recovery with no contact with other recovering people? Absolutely. We find them all the time. We find them in household surveys of all varieties. But they're unlikely to be that person who is enmeshed in a drug culture, agree? They're also lower problem severity and complexity. But we find it's an atypical, it's called acultural style, we call it solo recovery. Bicultural. Bicultural are people who can go in and out of AA or NA or WFS culture, but then on Monday they can go to work. They can deal with civilians. They got all the social skills to fully function out there and pass. You hear me? Nobody's going to, they don't even have, if they don't want to disclose, ain't nobody in the world going to suspect them as a person in long-term addiction recovery. And then we got people, do we have people whose whole world is a world of recovery? They eat, breathe, spend 24 hours a day inside that culture. And you know what? Thank God they may need to for a while. Because that may be their only shelter to relapse, is total immersion in that culture. And the recovery culture is aware of this. One of the things that will happen with this, I remember a point I was meeting with a sort of recovery mentor, and I'd hit with sort of this existential tough patch, and I was going in expecting him to tell me that I needed to get back and hit more meetings than I was already hitting. And he said, you know what? You need less meetings rather than more meetings. We're going to start a new program for you. It's going to be called the Get a Life program. What was he trying to do? He's trying to move me from a culturally enmeshed person in recovery to a bicultural. He said, once you get to be bicultural, you can choose. But I want you to have the choice. Right now, you're hiding. Right? You're hiding out. You're avoiding all those temptations out there, but you're only half well. Now that you're well, go change the damn world and get out there with them people. And then when you feel weak and vulnerable, get back here for your safety net. Personal identity. A recovery positive identity. If you bump into this person as a stranger in a supermarket, they will tell you their story. Are you with me? This person has no boundaries. They will talk about addiction and recovery in a heartbeat. And that may be about all they can talk about outside the drug culture, is that. Recovery neutral identity. It means, here, if we do a community survey of Atlanta, and you pick up the telephone, I say, is there anyone in the household who was once addicted to alcohol or other drugs, who today is in long-term recovery from that disease? Now, I've used some language, right? I've used addicted, recovery, disease, and I'll get a certain percentage of people who say, yes, we have someone in the household like that. Could I interview them for 10 minutes? Now, let's ask the question differently. Is there anyone in this household who once had a significant problem with alcohol or other drugs who today doesn't have that problem? What do you think happens to the affirmative yeses when we ask the question the second way compared to the first? Now, what's interesting is then in the interview data, we can actually check which met DSM-4 criteria for abuse or dependence. We have a lot of people who met DSM-4 criteria for a substance use disorder who will not self-identify themselves as an addict in recovery. But in fact, what? If you look at the exact criteria, they met the disease criteria and they don't today. They are what? Recovery neutral. They do not identify with that language. Do we also have people who are in recovery and because of the social stigma attached to addiction, they are deeply ashamed of their recovery? Can I tell a story on myself? This is deep. This is deep. I mean, this stigma is some nasty stuff. One day, I collect recovery paraphernalia because I got an addiction recovery institute that's like an historical archive. So I get T-shirts and buttons and stuff from all over the place. And people give me extra. They said, this is for your archives, this one's for you, Bill. So I could wear T-shirts from now for the next 100 years and not run out of T-shirts from all these marches and stuff. So one day, my wife and I are finishing up doing something, and she says, hey, will you run to the store and do this for me? And I said, sure. And without thinking, let me tell you what I did. I pulled off my recovery T-shirt that was pressed and clean. No reason to take this shirt off to go to the grocery store. And reached over and pulled on this simple white T-shirt without thinking. Then I get about halfway out the door, and I suddenly realized what I did. Man, I almost wanted to cry. I mean, here I am, like one of these super recovery guru type people, right? And in that second, what was my behavior telling me? Man, you're still ashamed. You know, you'll go out there and stand in front of all them people and speak at the marches, but you're still afraid to go to your grocery store with that addiction recovery identity blazoned across your chest. Man, that was like a moment of awakening for me of just how deep this shame we can internalize is around that stigma. Yeah, we got a lot of high-functioning people who are in recovery, but they ain't going to be part of our marches. You know why? Partially because of the high social status. They still remain deeply ashamed of their recovery status. Do we need to change that? We're going to talk later about how do we attract people to treatment. What do you think that kind of shame does in terms of treatment seeking? Will we have people who will only get to us? I'll tell you a story. I'm in my treatment unit one day and the doors bust open. Double doors, bust open. And there's this like entourage, about 9 people surrounding. I can't even see who's in the middle. There's this little woman in the middle, beautifully dressed. And they're escorting her in for admission to my addiction treatment unit. She's just been transferred from the second med-surg floor because she's got advanced alcoholic pancreatitis and cirrhosis. And she needs alcoholism treatment. Now, this is from one of our most prominent families in my community. And we treated her, and she never took another drink again in her life. And 7 months later, died from advanced liver disease from her alcoholism. Tell me why this woman had to drink till near death before she could walk through the doors of a treatment center. This is about stigma, my friends. Given that social status, she had to virtually be near death before the doctors would not give the family the option of not getting her to treatment at that point. It's kind of a neat story too, because she was in so much pain at the end, her family actually offered her alcohol. And she claimed, her classic words were, she rarely smiled, but she smiled that moment and said, I'm going out sober. Incredible. Styles. We have people who are professionally assisted into recovery. And that can be specialty treatment. It can be a private therapist. It can be a family counseling agency, a mental health agency. It can be somebody they encountered on a med-surg unit, their physician coached them, but they've got some professional guidance. Solo is we have individuals, for the most part, who initiate and sustain without any professional guidance. Affiliated recovery, we generally refer to people who engage within a recovery culture, like an AA or NA as part of that. The disengaged recovery is an interesting category. We generally measure the effectiveness of groups like AA or NA based on membership, right? You know, what's their active membership, how many groups? But here's an interesting question. How many people have disengaged from AA or NA, active participation, sustain long-term abstinence from alcohol and other drugs, meet our second and third criteria by way of global health and citizenship. Who've moved from what? They've almost moved from an enmeshed or bicultural style to, in late stage, sort of an acultural style. They now use family and social supports, and so they may continue to do service work, but rather than service work in the fellowship, they tend to be very actively involved in community service work in the larger community or through their churches or some other such thing. And we refer to this as an interesting style. It's a disengaged style. Now, this is interesting. What does that tell us we've done in terms of the overall influence of AA and NA and other fellowships? We have grossly underestimated the impact of those fellowships because we're not counting this whole large pool. Now, within those fellowships, there's a kind of mantra that says, you got to keep coming back. Because the people that we see keep coming back, they come in, they say, you know, I can't even tell you, I just stopped hitting meetings, man. I stopped meeting with my sponsor. And so the sort of what you learn is you got to stay connected. Because that's what the experience tells you. But the people we don't see come back, we assume they're all dead. And some of them are out there alive and well and kicking and doing great. And what we say this morning? Many pathways to recovery, and what? All are cause for celebration. Okay, here's a couple important ones coming up. Gender factors in treatment. We got a lot in the monographs on some of these. How many of you believe that women do worse in recovery? Because you know we talk awful about women in clinical circles. Counselors say, oh man, give me 5 men over one of them women clients. We hear they come in with all this trauma and co-occurring this and all the complexities of their life and all this messy stuff with kids. And you know, if you listen to that, you would think, my God, how the recovery rates for women should be awful, given all those burdens and complexities and obstacles to recovery. Can we just put all that to rest? I want you to hear me clearly. A higher percentage of women will recover in any environment compared to men. Period. If you say things like, I'm also talking about the fellowships. We talk about, oh, this is a white man's program, right? And historically, that's true. If you go back to 1939, when they say, these are the steps, we's a bunch of white men. No question about that. But people of color arrived in 1945, and women arrived actually even before 39. So the question is, do women affiliate at the same rate as men when exposed to recovery fellowships? And do we get better, worse, or the same recovery rates? And the fact is, we get better recovery rates for women coming into AA and NA than we do their male counterparts. So let's just set all that aside and celebrate how well women are doing in terms of their recovery rates. By the way, there are some differences we're finding. You know how we always say, you can't do this program for anybody else. You got to do this for yourself. Well, wrong. Because you know what? If we study women closely and we say, what were the factors that triggered recovery initiation? It wasn't themselves. In fact, if we waited for it to be themselves, some of them women would die before that happened. But here's what is it. Some very gender-specific factors related to recovery initiation in women. Family recovery. How many of you have family programs or kind of know about family programs? In the traditional inpatient programs, classic 28-day, third week of treatment, we bring all the family in, do family week. Monday, we teach the family members all about the disease of alcoholism and chemical dependency. By Tuesday afternoon, we're doing these elaborate psychodramatic family sculptings of all the family roles. Everybody's crying, carrying on, you know. Emotional self-disclosure and all this incredible pain in their lives. By Wednesday, we're kind of starting to talk about recovery. Thursday, we bring mostly men in, bring the men in, you know, to kind of see if we can start putting these relationships and families back together. And there's a lot of yelling and crying going on that day too. And then Friday, man, it's like Halo Day. It's like the families come together and we're going to leave and live happily ever after. And they come to the graduation the next week and they see everybody coming up and hugging and crying and giving the chip and they're graduating. We say, and the illusion is, not only is he going to have a great life or she, but the family, if they stay sober, those family problems are going to take care of themselves. Absolutely wrong. Early family recovery is ugly. Look at some of this language. While recovery alleviates many of the problems, and it will, many of those concrete, terrifying problems of active addiction will rapidly dissipate with recovery. But check this out. The early period can also be referred to as, what is this language? The trauma of recovery. You know what they're saying? Recovery is very destabilizing to families. And you know what? If recoveries don't have support going through it, the families won't make it through. He or she may make it through with their personal recovery, but they won't make it through with their family. What do you think the divorce rate is in early recovery? You know it's pretty high. What do you think happens to that divorce rate if we provide supports, not only to the individual, but supports for the whole family, through particularly that first 24 months? Those divorce rates will dramatically decline. I'm going to talk later a lot about post-treatment monitoring, support. Your first instinct is the person leaving treatment. What does this tell us? The unsafe, potentially out of control environment continues as the context for family life into the transition and early recovery years, as long as how long? So how long should we be monitoring and supporting this individual and family following treatment? Amen. Amen. Recovery-oriented systems of care. We got really 2 days. We're going to continue with some language. When we talk about recovery-oriented systems of care, which we're going to do a lot tomorrow. Tomorrow I'm going to talk a lot today about why we need to change and what those changes would be. Tomorrow, Dr. Achar in particular is going to talk a lot about how. How do we begin to transform these large, complex systems to move towards the kind of model that I described to you today? And when we talk about recovery-oriented systems of care, I want you to get this idea. We're not talking about simply transforming a philosophy of a treatment program. When we talk about the system in a recovery-oriented system of care is what? It's really about reorganizing larger environments to make them recovery-friendly. Let me give you an example. I could create a very recovery-oriented adolescent addiction treatment program in terms of what I did inside that bubble of inpatient treatment. And I would bring adolescents in who would soak up all the love we have to give them in 30, 60, or 90 days. And then I'm going to send them back to their schools and tell me what's going to happen. And I'm going to keep readmitting them, and let's be honest here, in some cases at $30,000, $40,000, $50,000 a clip in terms of the private insurance and the financial exploitation of adolescents and their families. I'm going to keep cycling them back through. That's not a recovery-oriented systems of care because what? We've had done absolutely nothing in terms of organizing supports. Now, here's how the thinking would shift. In a recovery-oriented systems of care, the way we'd think about that problem of recidivism is what are the environments? What we would say is this adolescent has mastered the art of recovery initiation. They do that very well. They've done it 5 times over the past 24 months. They don't need more practice in recovery initiation. The key is how do we move from recovery initiation in artificial environments, institutional environments, to recovery maintenance in natural environments. And for that to occur, we may have to move into that environment and build recovery support services for adolescents. Which means, rather than sit back and wait to readmit the adolescents for the 6th or 7th time, maybe we need to go to their schools and organize student assistance program that run recovery support groups inside the schools. Maybe every afternoon at 4:30 there should be a closed online recovery support meeting with all those kids who went through treatment together. Are you with me? Maybe we need to go into the life of that community and meet with H&I committees about the lack of young people's meetings in that community and the horrific problem we're having with adolescent relapse, and can we get some volunteers to begin to mobilize some young people's meetings in this community? Do you understand? It's a community organization perspective as opposed to a clinical perspective. Recovery-oriented systems of care. This is a macro-level organization of a community, state, or nation. Recovery management is a philosophical approach to treatment. Let's talk about the stages of recovery. Here's what I'm going to suggest to you. We have a stage of pre-recovery identification and engagement. Are you with me? Pre-recovery, we identify who's in need of recovery, and we begin to reach out and engage them in very active ways. In that process, we destabilize addiction. Addiction may be continuing through part of this process. We're trying to weaken and destabilize it, and we're trying to enhance recovery motivation. When we get to a tipping point of that, we then move to a second stage of recovery initiation and stabilization. Then we get to a transition to recovery maintenance. This is important. What it takes to maintain recovery is different than what it takes to initiate recovery. Are you okay with me on this idea? Okay, and tipping point. It's like the straw that broke the camel's back in terms of those crises. In some people, it is an experience of transformative change that is sudden, positive, and permanent. Right? I mean, it's like it may not be religious, but it is almost like a conversion experience. Let me describe a tipping point very quickly. We have a man in a community audience came up to me, big, huge public meeting. Came up to me and said, let me tell you my story. He wasn't involved, never been involved in treatment, never been involved in any recovery circles. He was raised by an alcoholic father who he detested. I mean, he still had this level of intensity of sort of rage and disgust in terms of all the stuff with his father and the violence, sexual exploitation of some of his sisters in the home, on and on. He said, I escaped home as early as I could. And very bright, used his education to do that. Went to school, went to college. In college, discovered alcohol, but was kind of leery of alcohol because of all of his father's stuff. But he said, I was always very careful. And besides, I was sure I wouldn't have a problem because my tolerance was so high. People kept telling me, man, you'll never have a problem with alcohol. God, can you handle your booze? I was always the designated driver, not realizing what? that in and of itself was a risk factor. So he says, I got through that, blew through college, went to a heavy drinking subculture called law school, right? Got through law school real good, got into a high-powered urban assistant state's attorney's role in one of these big departments. Super success. Worked hard, played hard, right? Worked all day, worked late, 10, 12 hours a day, and then they did some serious drinking deep into the night. Never missed a day of work. You got it? Okay. Does fine. Somewhere in the midst of that, gets a marriage. Blows through a couple marriages. Still has no effect. The drinking continues to escalate, by the way. Escalates in frequency, escalates in intensity. He has the following. One of the things he described to me was the thing he most detested, the image. I said, is there an image of your father? He said, yeah, my image is him coming home. And he said, when he didn't beat my mother, would pass out in the bed and be so drunk he would piss in the bed in his sleep. And my mom would ask me to help come clean him up and clean the sheets in the morning. And it just disgust, right? So I'm waiting like, where's this story going, right? And he said, I was 31 years old. I'd been home like 1,000 other nights. He said, yeah, the problems were increasing, but they were pretty subtle. It would have been years before I'd have done anything about my drinking. Passed out in the bed, woke up with the realization that the sheets underneath me were wet. That I'd urinated in the bed in my sleep. And he said, at that moment, what do you think he realized? I had become my worst nightmare. I had become my father. And he said, Mr. White, I've never tasted alcohol since the last drink I had that night. And that was 11 years ago. What happened here? We talk about tipping point? Woo! That's a tipping point, right? So you got our stages? Identification, engagement, initiate recovery, maintain recovery. That ain't in. Because then we got issues of quality of life for individuals in the family in long-term recovery. That's a whole different arena. This is not about just maintaining abstinence and some level of health. This is about really elevating the level of functioning. Now let's think about traditional treatment. Which of these we address? Do we go out and get people? We wait for them to come to us. So we do a lot in stage 2. Would you agree? A lot about recovery, initiation, and stabilization. That's acute treatment. We do that better and safer than it's ever been done in history, and better than it's ever been done in the world. What do we do with recovery maintenance? We hand you a chip until you go to meetings and get a sponsor. Or we tell you, now don't forget, we got this Tuesday night continuing care group. And we may run through 500 clients in a year. And how many people come to that group? Like 2? So my point is, I'm going to give you all the evidence later. I'm just going to be blunt. We do almost nothing when it comes to recovery maintenance. Even worse, what do we do with long-term quality of life issues for individuals and family in recovery? We're not even there. I mean, we're not even present in their life. How many of you believe, as I'm going to dramatically illustrate for you shortly, that recovery is incredibly unstable in the earliest days of recovery? Precariously balanced between addiction and re-addiction. Well, let's look at that. Okay, so these are the stages. If you look at the rhetoric, we have said that addiction is a chronic disorder since 1794. But we really haven't believed it because we pretty much treated addiction like it was a broken arm or a bacterial infection. And we've done it through, well, first let's look for some evidence. If we look at how does addiction compare to other chronic diseases, this is the work of Tom McClellan and others. Classic article in 2001 in the Journal of the American Medical Association, where they really said, look, here's the data on addiction, and here's the data on diabetes and hypertension and asthma. What do we find both in terms of compliance rates? Compliance with diet, compliance with education, compliance with exercise, whatever the recovery management recommendations are, we see that the compliance rates are about the same. We see the relapse rates are just about the same as these other disorders. We see these disorders are influenced by multiple risk factors. They're all influenced by voluntary choices. Agreed? Diet, exercise, medication compliance, all these involve issues of choices and how well I do. They have a prolonged course, and that course tends to vary from person to person. Here's some data for you. We looked at a sample of 1,271 treatment admissions, consecutive admissions, so it's a random sample, and we said this. What is the length of time from the first onset of use to the first year of abstinence for people who met DSM-4 criteria for dependence? And what do we find? How long are we talking about? Decades. Look at the midpoint. We're out here 25 years. Let's look at, this is another one where we looked not at use, but we looked at problems. So there's a long use period that may predate this, but if we said problems began here, how long between the first problem and the first year of continuous sobriety? And what do we got here? The median on this one is 12 years average. You want to talk about a prolonged addiction career? We looked at this one from when did treatment start to when the average time for the first year of continuous sobriety. And in this one, the average was 9 years. And inside that box over there, it says an average of 3 to 4 treatment episodes. All of these disorders are accompanied by risk of profound pathophysiology, disability, premature death. They all have effective treatments. You know, we can management protocol, but no known cures. That's pretty much what these look like. What we're saying to kind of introduce this shift we're about to make is if we really believed addiction is a chronic disorder, there are some things we simply wouldn't do. We would not create the expectation that full recovery should be achieved by everyone from a single episode of addiction treatment. And that if that doesn't occur, that it's a personal failure of that individual. Number two, we would not view prior treatment as a prognosis, poor prognosis, and also grounds to fail to admit this person. In fact, in the acute care model, if somebody's been treated at a facility before, we increase the probability they'll refuse admission of this person. So let me get this straight. The person who would actually know this person best is now refusing to admit this person because they no longer have anything to offer them. Number 3, we would not exclude clients for confirming their diagnosis. I just got to talk about this one for a second. You know, as a historian, I can tell you horror stories in addiction treatment. I can tell you of times we prescribed pounds of cocaine hydrochloride for the treatment of morphine addiction. And I can talk about mandatory sterilizations to treat alcoholism, and prefrontal lobotomies, and shock therapies, and every kind of drug insult imaginable. And you look back on those and you think, what the hell were they thinking back there? But you know, history's a humbler. Because, you know, you're obsessed with, as a historian, with, I wonder what they're going to say about us later. You know, if you jump out about 50 years and they look back, and what are they going to be saying? What the hell were those people back there in 2009 thinking about? Well, here's one, I promise you. I want you to look at this very objectively, as we would any illness. We admit someone for a disorder of addiction, or substance dependency, or a substance use disorder, on the grounds that they have a disease. And the essence of that disease is one of two things. One, an inability to abstain from using alcohol and other drugs in spite of escalating consequences. Or once a person begins use, they don't have a consistent shut-off valve. Are you with me? They can choose to start, they can't choose when to stop. So this person comes at our facility and they tell us they have this. And based on their verbal report and that of their family, we admit them. And 24 hours later, we find they have consumed alcohol or other drugs as an outpatient, through a drug test, or in our facility, meaning they have confirmed, they become symptomatic. They presented the actual symptom of the disorder for which they were just admitted. And as a result of confirming that they really do need to be with us, we administratively, or even worse, therapeutically discharge them from addiction treatment. Is there any other healthcare arena where you can get thrown out of a hospital or a doctor's office for getting symptomatic while you're there? You know what? History is going to judge us very harshly for this. Now, I'm going to be the first to admit, there are days people can be out of control in terms of their behavior. So they're not appropriate for a particular level of care. If I'm on a routine medical surgical floor, right? And all of a sudden I'm having a heart attack, I shouldn't be on that floor. I mean, I've clinically deteriorated and they're going to move me to ICU. But they're not going to throw me out of the hospital for failing to cooperate with them. And my point is that the issue isn't just that somebody got symptomatic and we needed to move them from res rehab to detox to restabilize them. But when we sever the relationship with them and punish them as if this was a moral choice on their part, history's going to be mean and ugly with us on this one. Number 4. We would not treat addiction in serial episodes of disconnected treatment. We would not relegate aftercare to an afterthought. Most importantly, we wouldn't terminate a service relationship following brief intervention. We're going to spend a lot of time comparing this afternoon. I'm going to describe 10 areas of clinical practice in frontline addiction treatment that are being transformed as we move from an acute care model of addiction treatment to a recovery management model. I want to begin by describing what an acute care model is. Number 1, it's an encapsulated set of services, meaning we screen, we assess, we admit, we treat through whatever our philosophy and methods are. We discharge and we sever the service relationship. We tell people goodbye, have a good life. And in fact, if I find David has been maintaining email contact with the people he treated in the facility, if I find out he's been calling those people, I may fire him because that's a boundary violation of professional ethics, right? So, I mean, it's going to get kind of squirrely this afternoon because I'm going to tell you, today David may be fired. In the world I want to create in 5 years, we could give him an award for how well he's done that. Number 2, a professional expert drives the process. What kind of power discrepancy? This is the expert model of addiction treatment. And what I want from a client is I want the client to come in and shut up and listen and let me tell them what they need to do. I do the diagnosis. I write the prescription of what they need to do. And if they don't do that, they're resistant and non-compliant. Next, individual, family, community is given the impression at discharge that recovery is now self-sustainable without ongoing professional assistance. That is what we convey, right? If we don't have long-term monitoring support plans, that is the message we are giving them. And the good news, as we said earlier, is some people's lives are transformed in this model. We do. We'll get about a third remission rates. Longer term. Those people with the clearest, simplest problem complexity and severity, with adequate recovery capital, will go through this and their lives can be transformed by it. But, and what we're going to do is begin to look at some of those buts. And this is going to be, we're going to begin to compare. As we break for lunch, I want to give you, we're going to do a little Q&A here just before we break. But I want to do one thing. I really want to emphasize this issue of acuity. How many of you believe that any healthcare institution should stay involved with the people they treat until the disorder being treated can be self-managed by the patient and their family on their own resources? So whatever that time is, and it's going to differ dramatically depending on what the disorder is, agreed? So let's use an example. Let's talk about cancer for a minute. When we intervene with cancer, and we do through a variety of ways, but almost across the spectrum of cancers, how long are we involved? Well, in some cases till they die, but there's an exception to that, and that's this. What we know in cancer is there's a high risk for reoccurrence of cancer within the first 5 years following primary treatment. So what do we do in that 5-year window of greatest vulnerability? I mean, and we do this, we're starting to do this very well in the United States. Some of you may have gone through, your families have gone through. What do? I mean, we're doing this incredible close monitoring and screening, and home nurses coming to visit us at home. When we won't show up, they come get us. We're going in, we're doing all the screenings, the blood work, and we keep doing that. And then when we get to the 5-year, what happens? Man, we celebrate. I got there. Because when we hit the 5-year window, what do we know? Because the odds of me relapsing later in my life have almost gone back to what it is in the normal population as far as the risk. But before I get to that 5-year, I know I'm walking on broken glass here. It's a scary time period. So here's the issue for recovery. When is recovery stable? Are you with me? When does my sobriety and health today predict sobriety for a lifetime? Do we have any data that helps inform that for us? And the answer is we do. Because when it comes to alcohol dependence, severe complex alcohol problems, we know the stability point of recovery is 4 to 5 years. Let me tell you how we operationalize that in research. We say, when does the risk of this person ever relapsing again in their lifetime drop below 15%? Below 15%. So what it says is, if you maintain 5 years of uninterrupted sobriety, you have an 85% chance of never tasting alcohol the rest of your life until you die. But before that, what? 4 years gets to be a little more predictive, 3 years a little more, 2 years sort of, a year don't tell us much. Doesn't tell us much. And 6 months doesn't tell us anything. Because there are a whole lot of people that have short periods of sobriety that aren't recovery. That's part of their addiction cycle, right? I mean, so that's not predictive of anything. That's part of an addiction career, not a recovery career. So if we know that 5 years is a stability point for alcohol, And for other drugs, we know it may even be less stable. For example, 25% of heroin addicts who achieve first 5 years drug-free from heroin, 25% will eventually relapse back to active narcotic addiction. So that's about 10% higher than the alcohol data, right? Now what about methamphetamine? Got no idea. What about cannabis dependence? Don't have a clue. Why don't we have a clue? Because nobody studied the recovery cycles. We haven't followed people out far enough to know. The only data we got is for alcohol, and even is prescription opiates different than the data we have for heroin addiction? Don't have a clue. Simply don't know. But if we use that data as a baseline, how long should we be involved? We said the principle was we stay involved until the individual and the family can self-manage that disorder on their own resources. We have no data on cocaine that goes out that far. Yeah, these are the first, these are almost all treatment samples. So these are individuals who've been treated. These are large samples. I mean, I don't think we've got a single sample that I'm referring to, the less than 1,000 people in treatment. The Chicago samples that we've done this work on, our data comes in a little bit lower. We get a stability point about 4 years. And after that, only about 13 to 14% will relapse. Absolutely, yeah. We got more statisticians than I can even count at this joint. These tend to be, for the opiate data, these tend to be large urban areas. These tend to be studies that have been done in San Francisco and Chicago and Detroit, particularly New York City. So there tend to be large urban, high African American populations within them in terms of both the old classic narcotic profile and a lot of the young polydrug and prescription opiate addicts that are coming in mixed in with that. But large samples. Okay, this is kind of the beginning of the crash course of laying kind of a groundwork for where we're going this morning. We're going to ask these questions this afternoon. If we really believed addiction was a chronic disorder, how would we treat it? We're going to ask the question, if you were only paid for successful recoveries, think about this one. If you and your organizations were only paid for successful recoveries, how would you treat addiction? Where everything that comes to you by way of resources would be contingent upon recovery outcomes, what would treatment look like? And as we've studied that, we're seeing, radical changes in the design of treatment. So our 2 modules this afternoon is we're going to look at how the acute care model changes when we move to a recovery management model and all these different dimensions of clinical practice. We have just a couple minutes. Q&A, I'm open to any questions before we break for lunch. Any questions or comments, either one? Yes? Yeah, would you, David? Thank you.
You spoke earlier about therapeutic community and TC, and you said that you emanated from that type of community.
Speak into it.
Aren't we really talking about a reversal right back to that same type of therapeutic community that we once talked about being too self-containing and too controlling? Because now we're talking about long-term treatment. And we're talking about a community that actually absorbs, that we can get to observe a client for 5 years or better. Yeah. But at one time, that was
Everybody understand the question? The question really was, I referenced therapeutic communities, and isn't recovery management that I'm going to be describing in some ways going back to some elements that existed before in the early TC? And the answer is going to be absolutely yes. It didn't exist so much in Synanon, because Synanon remained a very closed systems and then imploded. But it was very typical of Daytop in the early days, where they went out with community clinics and outreach offices and all kinds of stuff that David Deitch and others were doing. In Phoenix House, we're actually working right now, I work as a consultant with Phoenix House right now around applying this recovery management model to a TC model. And we're also meeting with all the TCs in Philadelphia in September to go through this process of and in some ways, I think 2 things are going to happen. We're going to retrieve parts of the old TC that got lost. But there are a whole bunch of things we never did in the TCs, ever. Like we never did 5 years of post-treatment monitoring. Now, there's an example. In the TC, if I'm a graduate, I got status to be connected to and sustained and supported, and people will come check on me. But what about the 90% who didn't make it through the TC? See, the difference is in the new world, we're going to monitor for 5 years everyone who was admitted, not just those who graduated. And the TC never did that. But the TC did what in terms of dose? Long continuity of contact, right? Really treatment in, live in, right? Work in, play in, treat in. Then you move out, come back for all your services. Then you move out and you come back as part of the community. I mean, you remain part of that community. That whole idea of using the community as a healing agent is going to be part of what you're going to hear this afternoon. Yeah. I'll give you, let's take another example. You know, the day, we're not going to go back and honor the days of shaved heads and diapers and humiliating learning experiences, right? Yeah, throw people, yeah. So, I mean, there's a whole lot back there that wasn't therapeutic. and we're going to bury that and bless that it's gone. Others, comments or questions from anybody before we break for lunch? Right here. David?
Right now, we talk a lot about relapse prevention. It's a part of the program. We try to give them a few skills and tools to when they're out the door. We hope that they don't fall again. How does that and that terminology fit in this?
Yeah, it's a good question. The question is, where does relapse prevention, our traditional focus on that? I've sort of agonized over that because there was always something about our focus on relapse prevention that just kind of made my gut squirm a little bit. And it took years to figure out what it was, because I liked some of the things we did, but I didn't like the conceptual framework. And I think I finally figured it out. Why are we not doing recovery promotion? Are you with me? The relapse prevention is a fixation on 1/3 of the recovery definition. How do I prevent you from picking up, right? But I haven't necessarily focused on what? How do I rebuild your life so there simply isn't any room for that in there? And rather than focusing on that, I focus on the positive. It's sort of an asset-based rather than a pathology-based fixation. There are a lot of people in the recovery advocacy movement, feel free to jump in, anyone who's here representing that, who think it's time we shedded the relapse language also. That the relapse language is a kind of stigma-laden language. That it may be, it's sort of this self-fulfilling kind of thing we do with that. Others, any other comments or questions before we break? Right over here, please. And then we have one here.
You talked about the need for more openness, like when you mentioned 52 people years ago and 40,000 recently, and that contributes to recovery being infectious, the more people who are more open. Could you say something about maybe a conflict between that and the benefits of anonymity and appropriate need for it?
Yeah. There are two. Let me do it at two levels. One is we're talking about advocacy with anonymity is the kind of slogan that we use. And the idea is we have deep respect for those people who are in 12-step recovery. But the anonymity tradition is not anonymity about personal recovery. It's anonymity at the level of press. Now what that means is we can have people, and we do in 12-step fellowships of all variety, on the streets, marching as a person in recovery as long as what? They do not identify themselves as they're not marching as an AA or NA member. Now, however, having said that, let me be clear. Stigma is real in this country. And people who choose to step forward can pay a price for that kind of visibility. So we're not out here sort of precipitously, impulsively challenging people in the earliest days of recovery to go out and be part of this movement. We're not even doing that with people in late recovery. We caution people, you need to have life circumstances that allow you to be able to take this, and you need to process this decision through your family, who may also be affected in some ways by this decision. So this is not this is one that needs, and the issue is that we don't want in fact, there are people in recovery, I don't want their face on recovery in the United States. Can I just be blunt? So, I mean, we don't need everybody, but what we do need is a vanguard of people that challenges all the myths and stereotypes related to addiction and recovery in the United States. And their stories are sort of the living proof and the testimony to challenge all those mythologies. Any other? Oh, I think we had a question over here.
My mind always goes to the money, about funding and how
Yeah.
to fund this type of recovery management system. And I guess I'm wondering, what are the policy implications that are happening at hopefully a higher level around Medicaid and those institutions that govern the way that we do business in the states and at federal levels? And I guess I'm kind of wondering, how to bridge that gap and to really sell this kind of system.
Yeah.
And that's a real concern for me, but also, how do you do it?
Yeah, and what I'm going to do is I'm going to beg your patience for 24 hours, or less than 24 hours. Because when we divided how we were going to present these 2 days, we're going to talk about why and what needs to change today, and we're going to talk about how tomorrow, including financing models. So, oh, that's horrible. That's horrible. Dr. Achar and I have already talked about how the design for tomorrow. We're not only going to address that issue, in general, we're going to talk about how do you do that, particularly in the states that are virtually facing these unprecedented budget crises. I'll give you my summary of it right now, and my summary is that the kind of community-based recovery management models that I'm talking about, that really involve lots of building of indigenous recovery supports, become even more important in this kind of economic environment than during the times where we're flush with money. I will also argue that because of some of the restructuring that is occurring because of those financial crises, this is an incredible opportunities in some way to look to the restructuring of some of those services. So, and we will really elaborate on that tomorrow, particularly describing how we have approached that in states like Connecticut and cities like Philadelphia. So I'm hoping you have somebody here to take notes for you.
I'm here. That's a great segue as we go to lunch. Can we thank Bill for a great
Thank you. Thank you.
introduction?
What do we really know about recovery? How many libraries could we fill if we just put the scientific knowledge base of recovery? What do you think the odds are of their recovery in this environment? So some people said people need recovery conducive educational settings. That the future of addiction treatment and recovery hinges on whether we are successful at that transformation. And that vote isn't in yet. Are you with me? This afternoon, we're going to get into the nuts and bolts. We're going to begin to start talking about moving from an acute care model of addiction treatment to this notion of recovery management, where rather than focusing on brief biopsychosocial stabilization, we really are talking about entering into a partnership with individuals and families and beginning to help them, and they're in the driver's seat. The recovery management, they're doing the managing. We aren't. Are you with me? We are partners, humble partners in this process, and consultants to them over a much longer trajectory than what almost any of our traditional models have been. This afternoon, we're going to say, what are the critical changes at the frontline clinical practice that occur in this shift? So we're going to look at 10 areas of practice between now and when we finish. And for each of those areas, We're going to say, this is what we've traditionally done in the acute care model. This is the problem with that related to the systems performance data that I'm going to give you. Remember I promised we were going to do a 4th step on the treatment system as a system of care? We're going to do that this afternoon with a lot of data. And then we're going to talk about, okay, given that data that talks about the incredible inadequacy of what we're doing currently, if we really began to shift toward a model of recovery management, not only what would that theoretically look like, but what is it looking like in the sites that are already beginning to do that? So that's kind of where we're going to go. The first area we're going to look at is really the issue of attraction. And that is, I want you to think about addiction treatment as a system of care, and we're going to ask this question. To what extent does the current acute care model of addiction treatment voluntarily attract into treatment the people in this culture, individuals and families who suffer from this disorder? I'm going to argue with you that one of the recovery-focused performance requirement is for the treatment of any disorder that system of care should attract people who suffer from that condition and bring them into care. And I'm going to argue that they should attract those individuals at the earliest possible point in the development of that illness. Because what do we know about chronic illnesses? I don't care which one we're talking about. The earlier the point of intervention, what? The better the long-term prognosis we got. Profound differences. Whether we're intervening very early or whether, in fact, I told you the story of the woman we brought into treatment who died 7 months later. She had a 7-month recovery story. Profoundly changed her life, believe it or not. She had a quality of recovery in 7 months that's comparable to people I've seen with 10 to 15 years of recovery. But think of the incredible waste that we're intervening with people who are terminally ill, who have months to live, regardless of our best efforts. Whereas if we would have intervened at the earlier possible point, think about the years and richness of recovery that this woman could have lived with her family. So we're going to begin. We're going to ask the question, to what extent do people who meet DSM-4 criteria for abuse or dependence, many of you have heard this figure before, which is in any given year, 10%, 1 out of 10, people who have a substance use disorder in the United States will enter specialty sector addiction treatment. That is all, 1 out of 10. I'm more concerned with another figure. And that figure is how many will actually see that treatment in their lifetime. And consistently that number is less than 25% of people who suffer from alcohol or drug dependence. I'm just talking about now the most severe category, will see specialized addiction treatment in their lifetime. Suggesting that 75% of the people with the worst alcohol and drug problems in this country will not see us. They will not enter this specialty sector. So we're going to ask the question, why? And here's what we find. When we survey people who actually have these problems, who meet these diagnostic criteria, and we say, why have you not sought treatment for that? Here are their responses. Number one, my problem isn't that bad, right? And your first instinct is to sort of blame them for that, right? Well, it's not the treatment center's fault, it's the client's denial. Let's talk about methamphetamine a minute, can we? Tell me about the images of methamphetamine addiction in the popular media in terms of what they look like. They look like somebody that just walked out of a concentration camp at the end of World War II. Agreed? We see this stick-like, emaciated figure. As we demonize drugs as part of anti-drug campaigns, we create caricatures of what drug addiction looks like. How many people do you think are dependent upon methamphetamine today who are still living in intact families, who are still employed, full or part-time, or in many cases working multiple jobs to make what they used to make in one job, right? And if they're asking the question, am I in trouble in my relationship with this drug, they see methamphetamines in some cases as sort of steroids, right? The only way I'm going to be able to work double shifts and support my family because I don't make $30 anymore. I make $8 an hour, and I'm working double shifts to support my 4 kids. This is not about getting high. This is about maintaining my ability to simply keep up doing what I got to do to take care of my family. And then we flash this emaciated figure on the screen to them. And they say what? My problem? My problem isn't that bad. How do the stereotypes that we portray popularly about people addicted to alcohol and drugs contribute to this in this culture? Here's the flip side of this. Are we doing anything to systematically alter that perception? Not in the general, I'm not talking about the general population. I'm not talking about some general education campaign so the public understands addiction. I'm talking about, are we changing the perception of what alcohol and drug dependent people look like in the eyes of people who are alcohol and drug dependent today and are in need of treatment? Is there any system-wide strategy that we have to do that? We do in this, yes, the closest we come is in Faces and Voices of Recovery. When people stand up and tell recovery stories, and and we see them bright-eyed and articulate, and they're describing their level of function and how they mask some of the worst problems they had, and all of a sudden now we're getting closer and closer to that story matching up with the stories of people who in fact need help today. So those are beginning to bring some people out of the woodwork. Let's look at the second one, perception of self. Even if I said, my problem's that bad, but I overestimate my capacity to manage this on my own. Right? This is something I can handle. I'm taking care of it. I've made some decisions about it. I've set some limits. I'm doing okay. Are we doing anything to help people test their capacity and speed up the recognition that they either in fact can handle this problem or know they can handle this problem and they are going to need some outside help? In our screening, tell me how we do that in our screen. Perception of self. I should be able to handle this on my own. This is a problem I can handle. One of my mentors is Ernie Kurtz. Ernie Kurtz is probably best known for one of 2 books, either the book Not God, A History of Alcoholics Anonymous. He's sort of the definitive AA historian. And he also wrote a book called The Spirituality of Imperfection. Ernie's well known in terms of his connection with the history of 12-step fellowships. What many people don't know was Ernie played an interesting role in the earliest days of the founding of moderation management in the United States. And he did that for an interesting reason. Ernie believes, and continues to believe to this day, that if we had effective moderation societies in the United States and moderation-based programs that would teach people the public health standards for moderate drinking and what those are, that it would dramatically speed up the number of people who attempted those and quickly realized what? Because, for example, the beginning of moderation management requires a 30-day period of abstinence. What percentage of people will never pull off that 30 days? So that might be your first clue that moderation management might not be the best choice. And then they have these sophisticated formulas around the number of days to drink, a drink count limit, and there are people, by the way, who will do that and actually manage and maintain those limits and do quite well with that kind of a program. But this person who overestimates their ability would quickly find out what under those circumstances. I had the opportunity of interviewing members of moderation management in New York City a few years back. And one of the things that surprised me was they said, you also need to interview AA members who started out in MM. And I said, oh, that's kind of intriguing. I would love to. So the people I interviewed were people who started out in MM, convinced they were going to use MM, and they were not going to go to any fellowship that made them stop drinking completely. Quickly found out, with every effort they put in to make this moderation thing work, it simply flat out wouldn't work. When I interviewed them, what do you think they told me? about if it wasn't for MM, how long they thought they would have continued to drink before they actually sought some kind of help for that problem. So, interesting, perception of self. Are we doing anything to help systematically test limits? I think we should be in every mall in the United States. I think we should be at every health fair. I think we should actually be coaching what responsible alcohol use looks like in the United States and what irresponsible, meaning people that got problems and loss of control, look like. So people can very early figure out that yes, they may have a problem and their management skills are not particularly working. Perception of treatment. If we go into drug cultures in particular, and we say, why aren't people, for example, addicted to heroin? Why are they not seeking treatment? What do you think we hear? The question is, what is our reputation, the reputation of treatment providers in the eyes? And they got 1,000 stories to tell you, because they know all the people that went to treatment and came back to them the day they got out to cop dope. Guess who they don't know? The people who left treatment and didn't come to them. So that's the recovery world is not visible to them. So if you think about the drug culture we talked about this morning, in that drug culture, treatment is an acknowledgement of what? You're a loser. You're not only a loser in terms of becoming addicted, you couldn't even be a good junkie, for God's sakes. So we almost have a stigma attached to treatment-seeking behavior. So the question is, how do we move into street cultures, if you will, in terms of illicit drug use in the United States, and really begin to alter the perception of treatment in the eyes? How do we take people who are in recovery, that usually disappear from those cultures, and go back and make contact with those cultures and put a face and voice on recovery? What do you think happens when we bring recovering people, come together as groups of volunteers, and go back in aggressive outreach programs to work the same streets they used to cop and shoot dope on for 25 years? And see the same people now. Now you want to talk about a powerful change in the perception of treatment and the change of recovery. And that's what we're seeing. One of the things we're seeing in recovery management models are these extremely assertive outreach programs that I'm going to describe to you shortly. But let's also look at this other one. What about the last one? Perception of others. Fear of stigma and discrimination. And you know what? They're right. Most stigma related to alcohol and drug addiction begins at the point you seek treatment, at the point you have a diagnosis. So what do we do with this? I mean, this is a legitimate fear. ADA didn't fix it. There are all kinds of circumstances a person may run into where they're going to be asked a question. Have you ever been treated for alcohol or other drug dependence? They could be in latest stages of addiction imaginable, but if they ain't been treated, they can honestly say, no. Well, you must be okay then. Perception of others, fear of stigma and discrimination. These are the major obstacles. What we're talking about in recovery management is when we talk about treating the community, when we're talking about building recovery-friendly communities. What we're talking about is beginning at a community organization level. How do we begin to educate entire communities to alter these perceptions? And how do we begin to get to very specific populations of people to alter these perceptions? I'll tell you places we could go to do very focused interventions. How many people do you think are arrested for DUI in the United States every year? We got a captured population to do that kind of focused education. How many people enter general hospitals in the United States with alcohol-related trauma in every 12-month period in the United States? We got a captured population to do this kind of focused education. And what we know, interestingly enough, is we're beginning to test these brief interventions by primary care physicians to do this kind of very focused definition. This is how you know you got a problem or don't have a problem. This is how you know if you can handle it or not handle it. If you need treatment, this is what treatments look like. This is what treatment looks like and the choices that are available to you. And by the way, if you think so, I think at least at a minimum, I think I should at least monitor you for a while. So why don't we reschedule you to come back in 3 months, and let's do a checkup on your alcohol use in the 3 months after you've left the hospital and just see how things are going. And in the classic motivational interviewing, when the client says, "Oh, I'm sure everything's going to be fine, doc," and the doc says, "Yes, I'm really looking forward to this glowing report 3 months from now." Right? Just roll with it. Go with it, right? Okay, let's go. Coercion versus choice. This is critical. The majority of people who enter addiction treatment in the United States today do so under external coercion. Can we just acknowledge that? How has that changed over the almost 40 years of modern treatment? We got any old-timers in here who can talk about the change in... I'm really talking about a broad category of coercion. Most people who are legally mandated to treatment. Talking about women who are coming into treatment under threat of loss of custody of children. I'm talking about people mandated to treatment through their employee assistance programs with a threat of job loss. I'm talking about physicians and lawyers coming into treatment under threat of loss of professional license. When we eliminate those categories, how many people do we have left in addiction treatment? Well, the trend is that and by the way, this is not an argument that coercion doesn't work. This is not that argument. In fact, we've got a lot of scientific evidence say coerced clients do as well as clients that are so-called voluntary. That's not this argument. But here's the problem with coerced clients. At what stage of problem development are people at the point they are externally coerced into treatment? We're in the latest stages of problem development. And so the percentage of people who are coming in voluntary, you know, the reason that percentage is so important is it gives us a little bit of an indicator of how many people are we reaching at earlier, less severe stages of alcohol or drug dependence. And again, at this point, we don't voluntarily attract those. When we look at recovery management as a model, when we talk about how is it different than sort of treatment as usual on this issue, one is that the folks that are beginning to sort of articulate what this model will look like in the future is we have very recovery-focused anti-stigma campaigns. We have campaigns really identifying sort of early intervention. What do you think this has done for the treatment of diabetes in the United States and hypertension? You have analogy when we talk about these very assertive campaigns. What do you think we've done in terms of breast cancer in the United States? This massive level of education. And by the way, I'm talking about in a lifetime, in 25 or 30 years, you could go back. I mean, in my childhood, cancer was not even hardly talked about out loud. And this was a sense of enormous shame and stigma attached to cancers and families. And you sort of found out kind of by word of mouth after people had died. But this was not something, particularly a condition openly talked about. And what about today? I mean, what's the pink ribbon campaign done for breast cancer in the United States? I mean, what would the equivalent of that look like for alcohol and drug dependence in the United States? We're beginning to talk about what would that look like, that same kind of level of resources put in. Is anybody familiar with the Recovery is Everywhere campaign? If not, can I just encourage you, go to recoveryIsEverywhere.com or .org. Do you mind? No, I can't remember which it is. recoveryIsEverywhere.com, or I can't remember if it's .com or .org. But you'll get an idea. This is a program called Dawn Farm in Ann Arbor, Michigan, who launched a very assertive anti-stigma campaign to really alter the perception of addiction, recovery, and treatment in their community. And they've done a marvelous job, and you can go and see all of the posters that they've used in that campaign. They've also encouraged, they've recruited a select number of local people who in a long ongoing series kind of put a face and voice on recovery in the local newspapers as part of the story. It's pretty remarkable. Assertive models of community outreach. I'm going to give you some descriptions of these shortly, particularly targeting hospitals, health clinic, workplace, schools, community centers. If the hospital and the doctor's office are very good sites for us in terms of early intervention with adults, What about schools? Really working with student assistance programs around doing early screening and identification and referral. Working with employee assistance programs. I am a real fan of jail-based outreach programs. I began my career in 1969 as an outreach, what we called then a street worker. And there weren't any treatment programs. You work with addicts on the streets. I worked in shooting galleries, and I worked in pool halls, and I worked in wino bars, and I would have probably 40 or 50 houses in the course of 3 or 4 days that I would constantly cycle in and out of. Pick up messages in pool halls of where people in trouble that I needed to go make connections with and that kind of thing. I made jail rounds twice a day, every day for 4 years. And a whole lot of the people in recovery that came out of that were people who their first encounter was me talking with them through bars, in a jail cell, in a drunk tank in some cases. I learned, believe me, I did. No, I think half of what I learned in the jail cells there, and the other half I learned it working in detox, right? It's a little different. Everything I learned in kindergarten. Mine was sort of detox. The jail outreach programs are a great way to reach people before the court machinery will find people and then legally get them to us. You're going to find a whole lot of people in jails. So the programs where we've got aggressive outreach programs going in, particularly when we've got indigenous people in recovery going into those jails who know an awful lot of people in those jails. Are you with me? And who were there as a person in recovery, who can tell their story and offer kind of living proof, in the eyes of a whole lot of people who really don't believe long-term recovery is possible. They see somebody in recovery and they're trying to figure out what their hustle is, right? And when they finally figure out that there's something real behind that apparent hustle, they begin to rethink that and open up some of those opportunities. We've reached, in the last 5 years, a lot of people in the United States through these jail outreach programs. I'm a real fan of them. Let's go on and talk about, I'm going to come back to this when we talk about motivation around outreach and kind of how it functions. The second thing we're going to talk about is, we started with this big pool of people who've got alcohol and drug problems. And what do we say? Out of that big pool, we got 10% of them, right? We got 10% of them that are going to get to us. Now, I want to talk about the front end of treatment. Of all the people who seek treatment from us, I want you to think about this. How many people call your agency for assistance who will never hear back from again? Then I want to know how many people will call and make an initial appointment but won't make it. Then I want to think about how many people will call and make the first appointment but we'll never see them back for the second appointment. So I'm really talking about issues of our ability to initially engage and access. Do we have a low threshold of engagement or do we have a high threshold of engagement? Traditionally in the acute care model, we've had a very high threshold of engagement. There are lots of hoops you got to go through to get into treatment. Agreed? There are a lot of obstacles to work out to get into treatment. In 1969, to get into most therapeutic communities, they had a very unique triage method. You had to call multiple times if you're a person on the street to get in. And I would call and they'd say, you got to call back tomorrow at exactly 10 o'clock, right? And being a good dope fiend, there ain't no way I'm calling at 10 o'clock. I may call 10 o'clock 3 weeks from now. So I keep calling, and they say, okay, you got to call back tomorrow. And finally I figure out what's going on here. I'm pretty smart. So you call 3 days at exactly 10 o'clock. And they say, okay, now you get to come in. So you get to come in, and then you get to sit on a prospect chair, right? Some of you know about the prospect chair. In the prospect chair, ain't nobody talking to you. You just got to sit there and watch the community for hours, right? In some cases. Now, the day that I sat down in the prospect chair, the first thing I saw was an African American about this tall, with shaved head except for a tuft of hair with a red bow in it, and he's wearing a diaper. And he's got a sign that says, I'm a baby, help me grow up. And I thought, what in the hell kind of cult have I got myself into? And then you would see all these other exotic things going through, you know? I mean, women with their heads almost shaved and exotic signs and weird rituals and people. I mean, it was a fascinating, it was like a zoo. It was like fascinating. And finally, you get called in from the prospect chair, and in this intake interview, right? You got to admit three things before this interview is over. I'm a baby, right? I'm stupid, and I need help. And the I need help ain't easy, because you got to, in this case, you got to stand up on a chair or a table, pull your pant legs up, remember? And you got to yell, I need help. And they said, everybody's yelling, we can't hear you. And you got these piercing screams, I need help. And oh, by the way, what are you willing to give us your car? Your hair? So, I mean, now, if you could picture somebody standing on a table, pant legs pulled up to their knees, screaming, I would say that's a fairly high threshold of engagement, wouldn't you? Now, it doesn't take long for word to get out what you got to go through to get into a TC like that, right? So what's that mean in terms of who's going to get there? What's the counterpart we got to that today? We have money counterparts, right? How much money you got to have get through doors? We got those, high thresholds. How many pounds of paper do we have as far as thresholds for people to get through? How many times do you think we have people so turned off by the sheer volume of mechanical questions thrust at them that they just turn around and leave? We get an incredibly, one is we get very high dropout rates from waiting list. The second we got a waiting list, what happens in terms of attrition of people? And we lose at least half. And the longer the waiting list, the higher the dropout is. You know, in the United States, we still have many communities where if I'm a heroin addict and I'm looking for a methadone treatment slot, there are communities today where how long may I have to wait for the very next slot opening up? 6 months, 9 months, a year, or longer is still not unusual. So if we do study of waiting list, how many people do you think we find who die on waiting list in the United States? It's high. It's high. Older? Yeah. Yeah. I'm too old for that shit. So, no, I mean, that's what you're going to hear. I ain't getting on no chair, you know. I've been on them chairs before. I mean, that's a person who's going across the street, and they're going to look for a lower threshold treatment program. If I come today and I say as part of the intake process, I'm in trouble with cocaine. I'm in trouble with cocaine. I need help. I understand. I got that problem. My efforts to manage that problem have all failed. I need help be outside myself with this problem. But why are you talking to me about reefer? Because reefer ain't never been a problem in my life. In fact, it's sort of been a solution for a good part of my life. If I'm not willing to buy this whole package of yours, because you're telling me the only way you're going to admit me is what? It's if I'm willing to look at total abstinence from all these. In other words, you're asking me to get well before you'll admit me. In other words, you're asking me to rewire my brain as a condition of entry to begin treatment. Now that's high threshold. Traditional, and very traditional, and current right up to today in many places. In a lower threshold program, we literally start with where people are at. If somebody's ready to work with cocaine, we'll work with cocaine. The only thing we ask is a commitment to reevaluate the rest of their psychoactive drug use as part of that package. You understand? I ain't asking for abstinence up front. So what have we done with the threshold? Because what I'm saying now in classic kind of stages of change theory is what? I've got a client who is in action stage related to cocaine dependency, but is in pre-contemplation related to their relationship with other psychoactive drugs. So we're going to start in action stage and then try to work with motivational interviewing and other strategies to move the client along to evaluate and rethink these others. But that's an outcome. It's not a precondition to get somebody into treatment. That's what I mean when I talk about lowering the threshold of engagement into treatment. In the places that we're experimenting with recovery management pilots, and I can talk very specifically, and Dr. Char, you may want to talk tomorrow about some of the homeless projects that we're doing. The city of Philadelphia has had a significant homeless problem for some time, obviously highly overlapping with issues of chronic mental illness and also issues of addiction. And those individuals have done very poorly in mainstream treatment systems in the city of Philadelphia. So they've created some specialized programs just for those individuals with the idea that we're not sure what the design should look like going in. They did something rather novel. Rather than set all kinds of preconditions on the design, they said we need to get to understand, we need to build a relationship with individuals in these circumstances. And out of the dialogue and partnership we develop, begin to evolve a design that responds to their needs. And out of that, they've come up with some extremely creative things. I'll give you an example. I was there many, many, many months ago when the program was kicking off. And one of the individuals there had been in the program for about 5 weeks, and he stood up and he did this really dramatic, raised up his hand real high and stood up and said, "I am somebody. I am a human being." And I looked at him like, what the hell is he? It was an identity card. He hadn't had an identity card in 11 years. He hadn't had a source of identification. And he was clearly had a Salvation Army suit on, trying to look as good as he could. I mean, this was a guy really trying, but it took, to do that kind of habilitation, took a program of longer dose, a very different kind of staffing mix, greater tolerance for all the boundary testing to engage this person. And they kind of figured out how to do that with this program. So now I want to tell you, this is months later. I go back last month, the city of Philadelphia, the mayor's Making a Difference dinner to celebrate all these people who've contributed to the recovery community in the city of Philadelphia. And I arrived just before it's time for me to go up and speak for my travels. And there's a bunch of people who come up, the kind of dignitaries, to kind of greet me and welcome me. And one of the things that I do when I travel a lot, particularly when I'm going to these kind of programs, is I give ties away. I give whatever tie I'm wearing that day, I give it to somebody early in recovery, right? Or I'll give them some other kind of chip or some other things. But I give a lot of ties away. So and on this day, I asked this person if I could give him my tie, right? And because I told him how touched I was with his story. So I got all these dignitaries who just met me, ready because I'm going to be speaking at this thing. And guess who I see peeking through the dignitaries doing this? He got this super clean suit on. And he's got what was once my tie from that pop. Isn't that incredible? I mean, this is an amazing story. He's got about a year now. And imagine somebody who hasn't had an identity card, who's lived under a bridge for 11 years, who now has a year of recovery. He would have never lasted in a traditional treatment program that long. We would have either had flight or he would have been thrown out for any number of reasons. High waiting list, special obstacles to treatment access. Weak engagement, dropout rates between call and first appointment. What do you think of this? 50 to 64% we lose. Let's talk about, as part of this engagement, right? I really want to talk about access and engagement. By engagement, I'm talking about the ability to build a relationship in which somebody can not only initiate but complete treatment. In the United States, more than half of 1.9 million people admitted each year to publicly funded addiction treatment. More than half will not complete that treatment. So let's look at the numbers and see what they tell us. 48% will complete, quote unquote. 29% are going to split. They're going to leave against staff advice across modalities. 12%, and that varies from 12 to 18% over the past 5 years, will be administratively discharged, usually for one of two things. What? Alcohol or drug use, one, or rule violations, which is interesting because a whole lot of the rules, when you think about it, have almost no connection to long-term recovery, right? I mean, they have a lot to do with lack of social skills and other, problems with authority. But there are a whole lot of people in long-term recovery that still ain't got real good social skills and still got problems with authority, and they're just doing fine, thank you. But we expel, my point is we're expelling a lot of people out of treatment for part of the very conditions that need to be treated. So we're really rethinking the circumstances on, can we create a friendly enough environment and stay connected enough with people that we lower the split rate and also dramatically lower the number of people we're extruding from treatment. And so does that mean that we rigorously evaluate those in a recovery management model? Absolutely. We see retention is absolutely critical. You talked about the 90-day service dose. Absolutely critical when we talk about 90 days across levels of care. What does it mean when we have these kind of numbers, that more than half of people will not complete a course of treatment? So these numbers simply have to change. High extrusion is a motivational filter. Kind of what we said in terms of like the prospect chair and all that, part of that was really a test. I mean, what it really said is we're looking for the people who really want it, who want to be part of this recovery community. These people who've got this internal motivation for this thing we call recovery. And we would get that, but it's creamy. You understand what I'm saying? This is not a representative sample of people who will go through that nonsense to get into a therapeutic community. So what's the alternative to that? I want to talk about who doesn't get in and who we throw out and who leaves early. Because it could be the people that leave early are the people who are getting well on their own. And we ought to celebrate that. I wish I could tell you that, but that ain't the truth. When we look at clinical data, what's the difference between people who complete versus people who don't complete? The people who don't complete are the people who need the treatment the most. Do you understand? They're the people with the greatest problem severity, the greatest problem complexity in terms of co-occurring disorders as an example. They have the greatest obstacles to recovery in their environment. So if anything, that ought to be the group. It's almost like if we could take everybody who needs post-treatment monitoring and support. Because right now, the only way it exists is with graduates for the most place in an acute care model. The people who graduate, we do follow-up and we say, we got a 90% success rate for the 10% of our people who graduate. Right? And we do. We try to build in a lot of support for our graduates because we're so proud of them. But I want you to think with me for a minute here. Who needs contact and support and reintervention the most? Not our superstars, but the people who in fact couldn't make it through that system.
Does that include those who are administratively discharged?
Absolutely. Absolutely.
That says something about the way we do treatment.
Yeah.
That might imply that the way we
Yeah? No. Say it. Go ahead. Turn, do the mic.
Yeah, I forgot what I said in all, but I asked him, did that include those who were administratively discharged as well? And he said yes, and then I said that might imply that the way we do treatment is the wrong way. Wow. But I'm trying to, I guess what I'm trying to say is that we probably need to be willing here today to make a commitment to changing the way that we do treatment
and particularly to fundamentally change how we perceive the relationship with people we've historically administratively discharged. I mean, this is a very different, what I'm really talking, we're going to get to the sections around monitoring. We're going to talk, but I want to get out of this. The people we expel are in fact some of the very people who need the closest monitoring, who can benefit most from that. And so, I'm going to give you something, a surprise here, who may be most responsive at the point you recheck and re-engage them. I'm saying I don't care what the circumstances are. I don't care how bad, how ugly a discharge is. we ought to have somebody there with the face and voice of recovery saying, would it be okay if we check back on and see how you were doing in the next month? Or could I give you a call next week just to check? And you know what? This person's ready to call us every name in the book until somebody says, can I call you next week? Sure, man, you can call me next week.
It's kind of like handing a packet of papers for someone to read and fill out that's coming to you to ask you to teach them to read.
There you go.
You know, I mean, it doesn't, if you think about it, it doesn't make any sense.
Absolutely. I want to talk about engagement in terms. Did you have a question or comment? Yeah, let me tell you. I work with in my early years. I worked with street cultures a lot, and so I'd sit around shooting galleries and listen to people talking about treatment. And when somebody's there nodding their head, banging around like the bubble doll in the back of an old car window, just shot junk, talking about, I got to get to that treatment program tomorrow. You know, if I don't, I'm going to go to prison next week, and all that kind of ramble. And somebody said, okay, man, here, let me tell you. I'll tell you exactly how you got to get in that program. Man, you got to go in, you got to talk about all them prior treatments you went through before. You got to talk about how you messed up, how your thinking's finally clear now. You got to take total responsibility for screwing all that up and saying this time's going to be different. In other words, they prepare the speech. So this person comes in and does the speech, right? And what I'm telling you, here's the message in the shift from treatment as usual to the new world. In the new world, motivation at the point of contact, initial contact, is not a predictor of recovery outcome. Everybody hear me? This is the science of it. You cannot predict at the initial contact by evaluating somebody's motivation or lack of it or their ability to verbalize it, who's going to be in recovery 2 years later. Because the people you think are motivated, I'm going back to my shooting gallery story, most of the time you're getting hustled. Do you understand? This ain't motivation, this is coaching. This is somebody who, as part of their addiction career, has had to learn how to manipulate their way into treatment for respite, not for recovery, but to take care of their habit, to lower their tolerance or whatever, right? To escape, get off the streets for a while because bad people are looking for them. So in the new world, motivation is an outcome of treatment. Authentic motivation for change is an outcome, not a precondition to get into treatment. Does that mean that we don't admit people because they don't have motivation? I'm saying lack of motivation is not a ground for admission into treatment. If we can get their body into treatment, that motivation is a shared responsibility, not the exclusive responsibility of a client. That's a new world. Now, let me put some stuff on that. I want to talk about engaging addicted women. I want to talk about women who fit this profile, because this is the group I got 20 years of data on. These are women with histories of abuse and neglect of their children within child welfare and child protection systems. These are women who may be as addicted to chaos in their life as they are the drugs in their life. Are you with me? These are women who are as addicted to toxic relationships as they are the drugs in their lives. These are women that when they come in and you do a comprehensive biopsychosocial assessment, the only question is who's more depressed at that moment, them or you. You know what I'm talking about? No, I'm saying, because at the end of it, you are so overwhelmed, right? I mean, to say, where in the hell do I even start with this, right? And what do you think she feels like having gone through this litany of stuff, right? So, okay, you gotta look, they're categorized as multiple problem clients and families. They've been involved in multiple systems. Okay, well, we find people like that, and we find them in recovery who have got no right to be in recovery. Because if you look at all the clinical data, they got no prognosis for recovery. So we come and we interview these women in this one project in Illinois called Project Safe. And we say to these women, tell us the story. I want to know how it happened. Now, I got to tell you, in the early days of Project Safe, this is like late 86 to 90, I'm so programmed in terms of traditional models of understanding how people recover, which is based on pain, right? It's a pain quotient. When the pain gets great enough, people let go, and there's this opportunity for change. So I'm listening for this pain, this hit bottom crisis story. I ain't hearing nothing like that. Not a thing. I'm getting these crazy stories. And so I'm finally telling this one, well, tell me, I'm looking, was there an incident that sparked this? Was there, something about the crisis? Her whole life's a crisis. There's no crisis. So finally she said, you really want to know how I got in recovery? I got in recovery because I couldn't get rid of that crazy woman. And I'm going, I ain't got no concept of crazy woman as a pathway of entry into recovery, right? I said, who are you talking about? And she said, that outreach worker from so-and-so. She said, I couldn't get rid of that crazy woman. She just kept coming and coming and coming. She said, that woman kept coming and she kept leaving me these mushy notes. Now, I got no concept of mushy notes in terms of therapeutic engagement. Boundary violations? Yes. She said, you know the kind I'm talking about. I didn't have a clue. It's like a Hallmark outreach series or something, right? She said, no, she said, you know the kind I'm talking about. She'd write this mushy stuff like, hope you've been having a great day, been thinking about you, love, sign so-and-so, the outreach worker. And she said, I kept tearing them cards up. And she said, she tracked me down in a crack house one day. Saw my car, stopped. I'm telling I won't even use the language, but it was bad. Describing the other women with her. I'm telling all these other women, okay, to shut up because she's out there and she's coming up. And here's this woman knocking on the door of this crack house. Say, Marcia, I know you're in there. I know you're too scared to come to the door, but I ain't giving up on you, child. I'll be back. Slid the card one more time, right? It was just amazing, So I'm hearing these like crazy stories. One of the stories I heard, one of the wildest stories I heard was a woman who said, I'd been hiding from this woman for 4 weeks. And I had to go back to my place to pick up some clothes. And I went back to my place, and here's this woman, and this was, by the way, this was an outreach worker we were actually worried about because she dressed pretty classy. A lot of flash, we were worried about her safety. She didn't care. She was proud of her stuff, right? We never could. She came and sat down to decide she was just going to wait for this woman one day. She's waiting like an hour and a half. This woman's not showing up. And they got this old scraggly lawnmower sitting over on the side and grass about this deep. Now I want you to picture this woman, says, I'm going to get this woman's attention in her high heels now, pulling this cord, gets this mower started, and this woman pulled up and she said, here is this crazy, insane woman mowing my grass in front of my house. Now I know you're all going, what on earth? Because that's what I was saying. I finally said to this client, tell me about the first day you went to treatment. She said, like 1,000 other days. I was out there ripping and running. My babies had been taken. I stopped by to pick stuff up at my apartment. And while I'm there, there's a knock on the door. I opened the door, and here's this woman one more time. I didn't say anything. I looked at her and said, don't say a word. Let's go. Now, I want you to think of this through with me. I'm describing 6, 7, 8 weeks. If I'm talking about aggressive, just short of stalking charges kind of outreach, right? So tell me what happened from the first day where she didn't want to have anything to do with this woman, but yeah, maybe she'd be okay if she came back sometime later, right? And don't say a word, let's go. What changed? Did the pain quotient in her life change in that 8 weeks? Not a bit. So what made the difference? I will not give up on you. Now, there were encounters the client later told me about. She said, I got in her face so bad telling her she knew nothing about my life and nothing about my business. And this outreach worker said, oh yeah, let me tell you what I know about your life. Let me tell you what it's like to have your children taken from you. Are you with me? And she said, that woman told some truth. So what happened? Let me tell you in the outreach workers' word. When I went and interviewed outreach workers later about these stories I was hearing, and I still was trying to make sense of all of it. And finally, one of the outreach workers said, here it is, assertive, these extremely assertive outreach models. The outreach worker said to me, Bill, you don't get it. My clients don't hit bottom. My clients live on the bottom. Bottom is the norm for them. And then what they said, and see if this fits for some of your women. These women have they have a greater capacity for physical and psychological pain than you can ever begin to fathom. Pain will not be a motivator at this moment in their life. And then they said something very profound. They said the issue the issue around initiating recovery is not an absence of pain, it's an absence of hope. Everybody with me? It is not an issue of pain or an absence of pain. The issue is an absence of hope. So what did the outreach worker do? Yeah, so we're talking about shifting technologies here from our traditional pain-based intervention technologies that are fairly coercive and rely on crises and accidents and pain of different varieties, and really shifting over towards recovery as a pull force rather than push, right? Pull meaning what? We begin to bring recovery role models into the lives of people addicted to alcohol and other drugs and provide living proof, in some cases, the people they used to shoot dope with, right? Used to live in the wino gutters with. I mean, living proof that there is a choice. Their life can be different. Powerful stuff. Appointment prompts and phone follow-up. I have a dentist office that has tracked me down in other countries to tell me I am due for my tooth cleaning. I have thought about filing stalking charges against them. I mean, that's how aggressive they are. I also understand there are financial motives for this, right? But I got to tell you, it's done marvels for my dental health over the years. Because I'm not motivated to go to dentists naturally. Can I just admit that? All the mainstream doctors' offices have learned what? They've learned how to help us manage by all those little nice things they do, all those appointment prompts and the telephone calls and the postcards. And we have clients whose lives are in absolute chaos. And we expect them to show up at our offices without any such technologies, right? Does that make any sense to you? So what does this tell you? You want to increase show rates in an outpatient clinic? There is an absolute technology to do that. All you got to do is reach out and begin to it's sort of like creating these very recovery-friendly offices that convey to people that what they do and them coming and continuing to come and participate is important to us. And guess what? We miss them when they're not there. Does this remind you of anything? I'm a historian of recovery fellowships, and I know there certain levels of service aggressiveness have gone out of style in certain recovery fellowships. But in some of those early histories of closed small groups, when we didn't have 1,000 groups a week, when somebody didn't show up, the group went and got them. I mean, and that's very much part of the early recovery stories of people who said, I would have never made it if that group hadn't virtually had the faith to come get me and drag me out of places sometimes early on till I got my first stretch of sanity in my life. Institutional outreach. Could we do something like what I described with the outreach worker inside a residential program? One of the questions we get a lot around this is we rigorously measure issues of engagement and retention because it's all about dose. You said it, right? No dose, no recovery. So we got to have dose, and to get a decent dose, we got to have retention. So we got to look in excruciating detail at what's happening for people to disengage with us. Well, I had a place in Michigan contact me many times, and we talked about different strategies of this. And what I suggested wasn't particularly helpful. And the director called me one day and said, I found the magic. We have dramatically lowered our split rate, and we've done it now for almost 5 months continuous. So we know that what we're doing with all kinds of different clients seems to be working. And I said, what magic have you discovered that we can market and peddle across the country, right? And he said, what I do is I have a requirement that each one of my staff must spend 30 minutes each shift of their shift walking the floor with no paper in their hands and no agenda. Doing what? How you doing? I heard your wife called today, right? And doing what? Constant re-engagement and checking in. I call this institutional outreach. You're inside an institution, but what are we doing? I mean, every hour by hour, we're checking in with people and checking their status. Now, in the old therapeutic community, we had that because what? Everybody in the community was expected to be doing that checking in. But in a lot of places, we don't have that. And we got staff locked up doing paperwork and locked up in staff meetings. So what's going on in the milieu when all of us are tied up and nobody's there working the environment? And we get the call about the girlfriend who may have a new boyfriend. Constant. If we're not there at that moment, the call is hung up. We've lost that person that day. So, I mean, it's very simple, very low tech, no dollars to it, but it really pushes this notion of moving out of the processing of people through schedules and activities to getting back to the sort of relational work of engaging and retaining people over time. I also talked about radically altered administrative discharge policies, which would suggest what? Mm-hmm. Yeah. Absolutely. How many of you think we have some clients that have chronic self-defeating styles of interacting with professional helpers? Everybody got that? Chronic self-defeating styles of interacting with professional helpers. And what we often get in these kind of incidents where we're throwing people out based on rule issues is we have these compulsive histories that get played out, and we don't even know they're getting played out. And by the way, they could be horribly embarrassing. Let me give you one very quick example. You know you are having a bad day as a clinical director when you get to work and all your staff are waiting for you. Including those who shift in at an hour earlier. And you know you're in trouble when standing behind them are almost all the current clients in residential treatment, also waiting for you. And when they got a spokesman, you're in trouble. So I arrive, this is the scene. And the spokesperson says, we need to talk to you. And of course, I'm looking at this sea of faces and saying, obviously, what's going on? Tell me what's happening. This man has made a mockery of everything this place stands for. And they described a client, this is like Thursday, we'd admitted a client on Monday. The client has wreaked havoc on every rule in the house for 4 days. And they go through, they list out all of these sins for the 4 days. And then they turn to me and says, and what are you going to do about it? I mean, the whole community. I mean, it's like my responsibility to obviously fix this man. So I said, well, it sounds like we need to have a little come to Jesus meeting with him. Go get him. And you know, in a classic kind of TC community meeting style, we did what? We kind of created some new orifices for him. Went through this confrontation on the unacceptable behavior, and we drew a line in the sand and said, the very next time you cross over this line, you're out of here. I've done this 1,000 times in my clinical career early on. So we do that. Very quiet day. Things have gone very well. He's done quite well that day. I felt pretty good going home. I get a phone call about 10:45. He won't go to bed. And we got a rule, lights out, everybody's got to be in bed at a certain time. So, okay, you're the clinical director, what are you going to do? You drew a line in the sand and said the next time you cross over, you're out of here. I threw him out of treatment. I don't know what you're going to do. And by the way, felt okay, pretty good about it, actually. I walk in the next morning into the treatment program, smiles on everybody's faces. It's like families after scapegoating, feels so good. And then the phone rang, and it was a judge. And the judge said to me, this is a judge, close friends, no bullshit with each other, close friends. Bill, let me get this straight. I send to you a man we both know hasn't lived in anything even remotely like human society for at least a decade. I send to you a man we both know has committed every kind of unthinkable crime. And you kicked him out of treatment because he wouldn't go to bed on time? And then he said, I sent this man to you for treatment, not for charm school. And slammed the phone down. You talk about embarrassed? I wanted to die. Now, you know how when you work with clients, you have them all sign a release of information to get those discharge summaries from previous treatments, right? How do you think I felt when the discharge summaries always show up long after you need them, right? Trickled in and described, I had 4 out of 5 histories that I'd actually got of he'd been administratively discharged in the first week of every treatment program he'd been in. Now, who do you think was in control of his treatment? Because it sure as hell wasn't me. And it wasn't the rest of the community. What do you think? You want to talk about being played? I mean, do you want to talk about a self-defeating style? Now, I don't know what that is. Several of you asked me at lunch if I could describe some strategies around women in terms of recovery management. So I want to I've tried to work some stories in, and I'll continue that. How many of you have had women who fall in love every time they come to treatment? And their sobriety is going to keep them sober, right? I mean, this kind of connection that occurs. Chronic self-defeating styles. How important is it that we know those? If I would have had the 4 discharge summaries before I admitted this person, might I have developed a very, very different strategy as a team of working with an individual who's been administratively discharged almost every time he's been in treatment before. Because I promise you, the one thing I would never do is kick him out of treatment. He could screw up in some new way, but he's going to have to get creative, because I ain't going to let him use the old way. I had a woman who said, this is an amazing story. First time I interviewed this woman, she was about 5 months in recovery. And one of the questions in my protocol was, of all the things you've been through since the day you were admitted to treatment, what's been most difficult for you? And she said, didn't hesitate, cocaine. Not using cocaine for 5 months is the hardest thing I've ever done in my life. And I'm back at 17 months. Of all the things you've been through since the day you came to treatment, what's been most difficult? She's one of the superstars. Everybody's telling me she's doing fabulous. And she said, I'm doing fabulous. Everybody thinks. And she said, oh, I'm staying clean. I haven't picked up since I came to treatment. My babies are doing great. And then she said, I get called on to do a lot of service work with other women. And then she started tearing up and she said, and I've never felt worse in all my life. She said, most days I feel like I'm going crazy. When you take a woman with this massive history of victimization and trauma and tear off that veneer and let her emotionally thaw out, right? And we're waiting for this joy of drug-free living to arrive. She may look superficially good on the outside, right? But this is going to be a tough journey. And you want to talk about a need for an ongoing partnership, long-term alliance to get her through that. I remember that interview just very poignant. And she said, do you know a good psychiatrist? I'm not even sure how I responded, but I felt very ineffectual in terms of my response. 10 years later, I'm back in this same program on a totally different project, and the director comes to me and says, do you remember so-and-so? And named this client. And let me tell you, first I remembered her partially because of that interview, but also because she was the first client in Project SAFE who got a college graduation. I mean, this is a woman who you would have never predicted. I mean, went back, did a GED, got into community college, went back, because she told her outreach worker said, what are your plans for your future? And she said, I'm going to be you. That was her long-term goal of recovery, where she was going to become her outreach worker. And you know what? She did. Went to school and became an outreach worker, working in the state of Illinois in the child welfare system. So she said, now there's the story. So the director says to me, she's back and thought she recognized you as that research guy and said she'd be happy to talk to you if you wanted to interview her again. Well, I'm talking now almost 12 years from my first interview, and we don't get a chance as researchers to do that too. So I said I would love to talk to her again. And pretty much use kind of the same broad outline to kind of review how things. And I got to the question, I said, now of all the things today that you've been through since the day you came to treatment, when you look over this whole time, what's been toughest for you? And she got real pensive and she thought, and she said, losers. And I said, pardon? And she said, losers. And then she began to describe this litany of very destructive intimate relationships in early recovery. And the only good news is each one got a little less toxic than the last one. And she got through it. And it was really a pretty prolonged process. The rest of her life was really coming together, but this area took about 5-6 years to kind of get together. And when she finished that, I said, when you look back at that, what was that about? I mean, how do you understand that today? And she got, again, really thoughtful. I'll never forget what she said. She said, what I understand today is if I'm attracted to them, they're high risk. Everybody hear me? She said, if I'm attracted to them, they're high risk. You want to talk about deep insight? Given the horror she's been through, she got rewired in some pretty horrible ways. So when she feels this sort of raw, driving physical passion, this is not the healthy zeal of the organs for one another. This is not about healthy sexuality here. This is about toxic chemistry, right? In fact, I thought later, we should hire these women to screen our men. Just put them in interviews for like 5 minutes. If she's the least bit attracted to him, put him in jail or treatment. Or both. Because he probably needs both. What do we got? What do you think this means in terms of a chronic cycle of relapse in intimate relationships? When you've got that kind of relationship pattern. How important is it to understand not this event of what it takes to stabilize this person, but what's the long course of the life story? And how is it going to get replicated in ways that are really going to screw up recovery? And how do we got to rewrite that story in some very fundamental ways to kind of create stability? And again, and do we have a partnership that will allow us to hang in with this person for a long enough period of time to allow that to happen? Let's go, I don't want to do that one. Let's talk about let's do a couple more of these before we break. I want to try to get to about the first 5. I want to talk about assessment and treatment planning in an acute care model. In the acute care model of assessment and treatment planning, we basically do this. The assessment process, if you will, is categorical, meaning it's focused, it's specialized. In the addiction treatment arena historically, we really focused in on the addiction history. And we kind of ask a few things around that, but if you really look at depth, this is a very specialized assessment. It's pathology focused in the sense that most of us are in systems that want us to generate a problems list out of the assessment data. Agreed? And the problems list is then going to drive a service plan or a treatment plan. And it's going to be professionally driven. The unit of assessment is the individual. We will spend, to be perfectly honest, very little time looking at family and extended family network in any depth, and almost no time talking about the recovery environment that this person is in. It's going to be essentially an intake function. We're going to do it once as part of the early intake and assessment process. Everybody with me so far? I mean, that's pretty much that. If you want to know, treatment as usual in the United States as far as assessment, that's pretty much what it looks like. This is what changes in the recovery management. We're going to explore why it changes this way. First off, the assessment process moves from specialized to global. And we have this new generation of global assessment instruments that emerged first with the Addiction Severity Index. Are any of you using GAIN, the Global Appraisal of Individual Needs? This is the one that is mainstream now, is used in most of the CSAT-funded adolescent programs in the United States. Both of those are examples of global assessment instruments. Pretty overwhelming when you first look at them. because you want to talk about a comprehensive assessment. It's almost terrifying in terms of the global range that's included in this. It's also, this new assessment world we're moving into is we're trying to move in to shift from a deficit-based instrument around problems and obstacles and barriers to really looking at cataloging recovery capital at 3 levels. Remember the term? Recovery capital, what's the internal and external assets that somebody has to initiate and sustain recovery. 3 levels. We're going to talk about what's the individual recovery capital, what is the family recovery capital that's going to help or hinder this individual, and what is the community recovery capital. Now this is an important shift because part of what the science is telling us is, remember I talked about this tipping point this morning? I talked about this fragile balancing thing between addiction and re-addiction. Part of what tips the scales for re-addiction or recovery is not what's inside the individual. It's what's inside the community. Could I predict adolescent recovery outcomes by predicting which adolescents are returning to communities with young people's recovery support meetings? Could I predict by which schools are they going back to that have some kind of recovery support structure inside the school building that's accessible throughout the day? Yeah, I mean the environment has predictors related to recovery capital. So part of what we need to do is assess the recovery capital at those 3 levels. Because part of my strategy might be is if I've admitted this, as I said this morning, if I've admitted this adolescent for the 5th time, but this time I'm going to assess the community recovery capital and I find none, then maybe part of the strategy for this admission is that I have a case manager who works not with the client, but works aggressively with the community over the next 60 days to basically prepare for this adolescent's reentry. We're actually at a point where we're sending recovery coaches home with kids. What do you think of that? In other words, if we're having this huge gap where you fall off the table between treatment and the real world, why don't we send a recovery guide to be a personal consultant with somebody in the first 72 hours as part of their reentry and do daily telephone coaching as part of that process? Or can we arrange for peer recovery supports within that community who will take over that function? Greater emphasis on self-assessment versus professional diagnosis. Scope of assessment includes these 3 domains. This piece is critical. The assessment process is not an intake function. It's continual. In fact, in the best of all possible worlds, if we're recovery focused, we may actually have less assessment work up front because the focus is not on assessment, the focus is on relationship building. Are you with me? And then in the context of and by the way, you know why that's important? Because a whole lot of what you get in the relationship, the initial assessment, has no legitimacy to it in terms of accuracy if you don't have a relationship at that point anyway. How much do you think the answers to some of those questions will change in day 2 compared to day 10, once we've actually got a therapeutic alliance going with somebody? So that shifts pretty dramatically. Continual. How many of you believe that recovery has developmental stages? Right? That people go through different developmental stages of long-term recovery, and that when people shift from one stage to the next, their service needs may dramatically shift. And the service relationship may need to dramatically shift from one stage to the next. I mean, this is sort of real basic stages of change theory around addiction recovery. But here's the question. If we actually buy that, how can we assess one time? How can we assess one time if we assume this, if we actually truly believe that there are these stages and when people make the shifts? Do any of you have a sense that some clients come into treatment and do very well, partially because we have a very good match, stage appropriate, the work we're doing and the work they're doing. And we're so proud and pleased, and they're one of our early superstars. And then it's like they hit a wall and all too often self-destruct right in front of our eyes. This is not the worst client going bad like we expected. This may be the best client that we had such incredible hopes for. All of a sudden clinically deteriorating right in front of our eyes. I would suggest the client may have shifted stages and we don't know it. And what we've got is a horrible mismatch now between what we're doing in terms of service activity and what this person needs. In this model, what it says, like by the way, any chronic disease, If there's any substantial change in status, what is required? Reassessment. And the reassessment, by definition, must be global each time. Because it may not be something within the addiction recovery arena, it may be something peripheral and outside of that that's rippling in and affecting that. The reason that all assessment must be global is in chronic diseases we have this little parable, and it says this. Chronic diseases beget other acute and chronic diseases. Do we know that over time? Think about diabetes. If I have diabetes for any length of time, what do we know about it? I mean, even under the best of conditions, how vulnerable am I to an incredible range of collateral, physical disabilities and problems? So every time I go to the doctor, if I go to the doctor with that condition, they got to talk about my feet every time I'm there, checking on them, right? And a whole bunch of other things. But my point is, you got to look at the whole, this global range each time. And we got to do it in the context of understanding these changes. Rapid transition between professionally directed treatment plans to client-directed recovery plans. This is huge, huge. Classic article, Thomasina Borkman, Journal of Substance Abuse Treatment. Title of the article is Recovery Planning Different than Treatment Planning? And her conclusion is, it is radically different. And so if you want to know about recovery planning, it's Thomasina Borkman, Journal of Substance Abuse Treatment. I think the year was 1994, I think. But it cited many of the monographs, so you'll be able to get it. The recovery plan is client-generated. If we're very nice, they will give us a copy. In contrast to the treatment plan that we coerce them to sign to create the illusion that they've actually had some kind of participation in it. Service elements. Just a couple of these. I want to talk about the changes. Obviously, we move towards a kind of evidence-based process. At the same time, we're very aware that a whole lot of things that may be extremely effective in long-term recovery support, we simply have no research on. So we don't have science to guide those. But by evidence-based, what we're really talking about is we have a commitment to evaluate the effects of the ingredients that we're using as part of the treatment program. And what we're suggesting is this. For many of those core ingredients, we're going to have clients who optimally respond to those. Are you with me? People who partially respond to those. People who don't respond to those at all. And this is the next very important one. Some people who may even be injured by those. And it could be, what I'm saying is the same strategy that actually enhances your functioning could actually create clinical deterioration. We always, what is this? This is about side effects, right? Like we do with medications. 99 people out of 100 respond marvelously to this drug. The others develop liver failure and could die. The term is called iatrogenic illness. It's treatment-caused harm or injury, and we need to constantly, rigorously evaluate that. Does that mean even in things that we have warm, gushy feelings about? I'm doing a lot of work organizing peer-based recovery support services all across the United States. And I'm seeing them do amazing things for people in terms of their long-term recovery. But do I need to be aware that there could be harm done in the name of help within peer-based recovery support services, just like there's been harm done in the name of help of professionally directed addiction treatment? And we need to be cautious and figure out how to monitor and prevent that. Absolutely. And we need to do so very vigorously. Minimal individualization of care. How many of you have what you call a very strong program? Program, meaning that, particularly in residential settings, the program, right? The program does the work. We just sort of manage the program and oversee it. Clients get up at a certain time, eat at a certain time, go to community meeting, go to lecture one, go to group, you got me? The program. Everybody goes through the program. And when we operated on the idea of, we have a single pathway model of addiction treatment, one unknown cause, and if you got the bug, it looks like this, and it responds to the program here, and then you get long-term recovery. When we had that view, that seemed to make a whole lot of sense. But if we take on the notion that we actually have multiple etiological pathways, multiple patterns and subpopulations, who need very, very different treatment interventions and have different styles of long-term recovery, maybe the program's got to be rethought a little bit. Would you agree? So part of what's happening in recovery management, to a great discomfort of a lot of staff, because to be honest with you, I finally figured it out. The program is really for the staff. Okay, I'm serious. I mean, it's nice. I mean, I love the structure, love the security. I love giving that lecture, you know. I'm crushed that they don't want it anymore. I mean, it's really about the staff. In the recovery management model, where we end up is we end up with a very, very large menu of potential treatment and recovery support services that are individually applied, uniquely combined and sequenced, and at times thrown away when none of them seem to fit the client we have in front of us. And if they need things we don't have, as a clinician, my responsibility as a clinician and advocate is to what? I got to find ways to generate it. And if we can't, I need to admit I can't do it here, and I need to get this person someplace where that can happen. With me? So, but what kind of strain does that put? How much skill do you need in that kind of system compared to the program? Because, I mean, you got to be smart. I mean, you got to understand a lot of stuff, right? And you got to apply that very individually every day and make those, so it's not easy. It requires a whole lot more sophistication. What does it require by way of supervision? You know, in the clinical supervision on a lot of places in the country has deteriorated to paperwork supervision, right? I mean, let me just be honest here. When we debrief clinical supervisors, they're the ones say, you know, we're not doing clinical supervision like we used to, or like I had. Haven't done it for years. We're doing good if we can supervise and just keep up with the flow of activity in the paper. But when I'm talking about this kind of model with this incredible service menu, we need good clinical recovery support supervision to see how that person's responding. And if not, we got to think through what are the combinations that are going to work best for us. My guess is you probably have some very good women's programs in your state. Would you agree with that statement? We've created gender-specific treatment in many of our states, and the people who've worked in that have really rewritten fundamentally our understanding of addiction, treatment, and recovery of women. I mean, you can find enormous expertise within some of these specialized tracks. And that's great. But can those be appended to large treatment systems that treat large numbers of other women who have no access to any of that understanding and any of that service technology? Or what about other programs who don't have women's programs but treat women in the mainstream part of treatment who have none of that knowledge? In recovery management, what we're trying to argue for is the issue is not creating specialty appendages. The issue is not that you've got 2 or 3 or however many programs in Georgia that really understand, that really get it about treating women and their children and families. The issue is can a woman in the state of Georgia walk into any addiction treatment program and get access to that kind of knowledge and understanding and those kind of services? And we can't right now, right? I mean, so what we're talking about is we're starting to say, how do we take these little pilots where we've got all this incredible stuff going on, how do we begin to mainstream some of that? Let's look at as we move, we talk about evidence-based, high individualization, emphasis on mainstreaming services that are gender-specific, culturally competent, developmentally appropriate, trauma-informed. So the question is this simply like a new flavor of the month? Is like recovery management is this month, and cultural competence was last month, and trauma-informed services was the month before? And what we're beginning to try to say is, no, we're not talking about replacing any of this. I mean, if you're going to do recovery-focused systems of care, recovery-oriented systems of care, they in fact have to have these kind of dimensions. Recovery simply becomes the larger organizing framework within which those kind of services evolve. Number 5, just 2 quick things, and we'll take our afternoon break. We use, in a traditional acute care model, we use a lot of medical metaphors, agreed? We spend a lot of time talking to clients about their disease, their illness. We use a lot of medical model kind of language. So tell me this. How much time do clients spend with physicians and nurses in addiction treatment in the United States as part of their treatment? No, I mean face to face. If this is in fact this kind of significant medical psychiatric illness, how much time do staff spend with healthcare professionals by way of physicians, physicians' assistants, nurses, clients? Yeah, once there's been a sign-off. I mean, we're really using medical staff as gatekeepers around payment approvals and levels of care placement, as opposed to what? So let's be really honest. Apart from processing and payment, physicians don't have a significant role in most addiction treatment programs in the United States, particularly in the public sector at this point in time. And nurses are having less and less, if you really look at how that's unfolded over 40 years. So what do we do with that? Well, recovery management starts with this assumption. It says every person in long-term recovery needs a relationship with a primary care physician. Crucial. Needs a long-term relationship with the primary care physician. Just like anybody with any chronic disorder needs what? Needs that kind of relationship with continuity of contact over time. They know you, they're your partnership, they're your partner and consultant in the management of this disorder. So what we're getting is, within the recovery management model, we're trying to experiment with bringing primary health care clinics into addiction treatment programs. We're trying to work with medical schools. We're trying to work with, what about our clients who don't have any primary health care? Don't have any primary physicians? What we're saying is, if you're thinking about long-term management, I'm going to talk to you this later this afternoon about recovery checkups as a formal mechanism over that 5 years that we talked about earlier today. One of the people who has a critical role in that recovery checkup process is the primary care physician. Even if the client disengages from us, that primary care physician, if they've got a good alignment with that client, may still be significantly involved, can do the recovery checkups, and when needed, get that person back to us for support. Next issue around service team. Yes?
But most of the time, physicians are the hardest ones to get over to that model.
You got to train them. The issue is not getting somebody just because they got an MD after their name. What do we have? The issue, I should have been more explicit. Every person in long-term recovery needs a primary care physician schooled to understand something about the processes and stages of long-term addiction recovery. Is that better? Yeah. So that really says we have some responsibilities not only to recruit those physicians, but also to be involved in creating training resources for them.
Just a question. I guess the question is, primary care physician, as relates to the team approach, should be part of the clinical team. But because of dichotomy, because of professionalism, there's sometimes a bit of separatism. I'm using that very mildly.
Yeah.
So therefore, therefore, you have this higher echelon of staff who feels that they're separate, but you need to be involved.
Yeah, the point you're raising is an excellent one around how do we integrate then, if we bring this primary physician in or these nurses in, how do we then really begin to integrate them into the team and do that over time? And again, two things are happening. With the primary health care clinics, we're bringing the clinics in, so we're actually bringing primary medical services into the... If you're dealing with a client group with high co-occurring disorders such as hepatitis C, HIV and AIDS, multiple other complicated acute and chronic medical conditions, what more appropriate place to put a clinic initially to engage and stabilize those than right in the addiction treatment setting? The second thing is there any reason why we couldn't have addiction professionals actually working part-time within offices of primary care physicians throughout the United States? That if in fact, remember, I want to go back to our screening, right? When we talk about how do we do this early identification? If every annual physical in the United States included an alcohol and drug screening question that takes about 5 to 6 minutes, and if there were any kind of risk factors raised in that interview the physician referred to the counselor that works part-time aligned with their primary care office, right? So we got both, we're bringing the physicians towards us, but I'm also saying there's another role in recovery management of us moving towards and actually beginning to provide offices or services in primary healthcare settings. One other piece, final piece before we break, around composition of the service team. We use a lot of recovery rhetoric in addiction treatment. What has happened to the representation of people in recovery in addiction treatment settings between 1970 and 2009? If you look at my monograph, it's gone from, actually in the late 60s, near 100% in some settings. I'm thinking about some of the early therapeutic communities, for example, of that era. The place that I was treated in 1969 had no professionals working for it at that point. 100% of the people were in recovery. Now, to be honest, though, at that period, the early rise of treatment, there was usually about a 70-30 mix. About 70% were people in recovery, about 30% were multidisciplinary professional staff. Nationally, no, was not. No. Most of the early therapeutic communities of that era were headed by ex-addicts. Phoenix House might have been the exception with Mitch Rosenthal. So my point is, through the professionalization, right, we dramatically lowered the representation of recovery people in staff roles. We also then, by attrition, lost our volunteer programs. Agreed? We lost many programs lost their alumni associations, or they may have one in name, but they're really vibrant alumni associations, where you'd have 200, 300, 400, 500 people showing up for events. I mean, those are kind of like in a memory. They're really the exception. So I want you to think about what that meant for people going through treatment in terms of exposure to a large number of people in long-term recovery. That number has dramatically shrank over the years. And through professionalization, if we have individuals in recovery as professional addiction counselors, they may be coached within their programs. They cannot disclose that status. And if they do, it's seen as a boundary violation in their relationship with clients. I mean, that's how far we've come in 40 years in terms of that role. What you're seeing with recovery management is very interesting. How important is it, do you think, for people who are diagnosed with cancers to meet survivors of cancer? I mean, it's that same kind of thing. We're saying there are some functions that occur in terms of recovery that we desperately need people to come in and offer the living proof of those statements. So to bring people back in, we're sort of bringing in a whole new role as we push recovering people out through professionalization with all the escalating educational requirements and other things. We're bringing them now in the back door through the roles of recovery coach, recovery support specialist, outreach. Some places are still using the case manager term for people who are in recovery. We're seeing a renewed emphasis on volunteer programs. We're increasing consumer counselors, alumni associations. It's sort of like recovery representation is becoming, again, a huge issue. And at a local advocacy agency, people are coming to treatment programs and saying, how many recovering people you got on your board? How many recovering people? Do you have staff representation of people in recovery? It's almost like a disabilities rights movement. Nothing about us without us. If you're going to make decisions in this community critical to the lives of people needing and in long-term recovery, we need recovering individuals and families at that table in those policy discussions. So this is the political and cultural awakening that I talked about earlier this morning. The other thing that we're beginning to do is we're recognizing the role of indigenous healers within particularly cultural communities and their role in the long-term recovery process. In the city of Chicago, we asked the question, one of our studies, is recovery for African American women different than for their Caucasian counterparts? We had a ton of theories. We were going to prove, write it up, publish, get rich. I mean, we were hot on this. We knew what we were going to find before we did it. That's the first sign of bad research. And sometimes data is very humbling. Because when the data rolled in, at 3 months, 6 months, 9 months, and 12 months, we compared all these white women with all these African American women. And you know what? We didn't find diddly squat. But when we went out 15 months and 18 months, it was like they split. And they split by race. Let me tell you a key question. We asked the question, what is your primary sobriety-based support structure today? Who are the people most important to your sobriety today? And in 3 months, 6 months, 9 months, and 12 months, all them white women, all them black women were saying AA and NA and my recovery home. I mean, very traditional recovery support resources. The second we got beyond a year, they talked about their churches. Okay? They talked about their pastors. They talked about recovery ministries they'd found. They didn't say they didn't necessarily stop going to 12-step programs. But when they said the most important source of support for your recovery today. And you know, we asked the question, why 12 months? I mean, if it's that important, why wasn't that it number one at 3 months? You know what they told us? It took me a year clean enough it took me a year to feel clean enough to go back and make connection with that institution. Now, I think that's changing, by the way, now. I think the times are even getting shorter now. Because I'm describing time 80s and early 90s when the churches didn't exactly have big welcome signs out. But today they do. So I'm suspecting that's going to be earlier. Here's the point. If as in this example, we know that many African American women and men may even use different religions to do this, agreed? In one of our studies we found women migrating towards Christian churches and a number of our men moving towards Islam. Nation of Islam in particular. So my point is simply this. If we know that that women in this community, many of them will migrate towards churches and faith-based ministries to sustain their recovery over the time, who needs to be at the table with us? If we do not have those churches at the table with us, it is unconscionable. We need to be reaching out into the lives of those churches and inviting those churches into our lives to be available as a choice for support for those women. And it's not a pre-existing thing that says I'm biased because I like that. It's simply saying whatever that indigenous culture dictates is a pathway of recovery. In the Native American communities that I work with, do you think there are indigenous healers and healing rituals within those communities that are crucial to long-term recovery? Absolutely. And if so, how should they be involved with us as a treatment institution? We need to break down I want you to begin to think about treatment without walls. Are you with me? There's not a boundary between the treatment institution and the natural communities of those we serve. And as we think about if we're going to help this person initiate and coach them into recovery, what are the sources out there that are going to help sustain and nurture and elevate the quality of that recovery? Then we need to invite them in so we have this going on. So there's a seamless process between recovery initiation and recovery maintenance. Let's take a break. We're working too hard. What do we really know about recovery? How many libraries could we fill if we just put the scientific knowledge base of recovery? What do you think the odds are of their recovery in this environment? So some people said people need recovery conducive educational settings. That the future of addiction treatment and recovery hinges on whether we are successful at that transformation. And that vote isn't in yet. Are you with me? Number sixth area of practice, really is the issue of locus, where we deliver services. In the modern history of addiction treatment, we've become very institution-based. We have fallen in love with our buildings. And you know what? The nice thing is they're much nicer than they were when I started, I assure you. So the general theme is if you call me and say, Bill, my brother's drinking himself to death, my general stance is, will he come talk to me? Can you bring him to me? Can you bring his family to me? The issue is, how do we get that person from their world into the world of treatment? Sound right? I mean, that's mostly what we're trying to do, is get people to come to us. In that process, we have had, as we've disconnected from those environments, we have had a fairly weak understanding of the physical and cultural environment in which people are trying to initiate and sustain recovery. One of the projects that I was serving on as an evaluator on, I got a phone call one day, and the director said to me, "Bill, my staff are about to kill each other. If you or somebody doesn't get in and take care of some of this conflict, you aren't going to have anything to evaluate." She was very serious. And what she was talking about was this incredible conflict between the counselors, the clinical staff, and the outreach workers. And it was really about what realistic expectations were for women, particularly early in treatment. Where are my child welfare folks at? Where are you at? This was one of these projects. What are the realistic expectations for women in the first 2 to 3 weeks of treatment? And so I went out. I was kind of panicked about, I didn't want to lose this project as a research site. So I went out, interviewed the outreach workers, we tried a bunch of things. A lot of stuff didn't work. Let me tell you what worked profoundly. We set up a requirement that every therapist in this program had to go visit their client in her natural environment at least once a month. And I'm telling you, the therapist, you'd have thought I'd asked them to commit suicide. Because, I mean, they just about were ready to start. They said, "It's not safe out there." And of course, I had to say, let me make sure I understand. Because you're telling me it's not safe for you to go out with the outreach worker at 7:30 in the morning to visit this woman's home before things get busy in that neighborhood. With me? 7:30 in the morning. It's not safe for you. But you're going to throw her out of treatment if she doesn't move through that same environment back and forth to AA or NA meetings 3 times a week between 8 o'clock and 10 o'clock at night. Is that what you're telling me? Oh, well, what do you think happened when we actually got the therapist into those environments? You want to talk about an eye-opener. You want to talk about a humbling experience. The outreach workers knew, but I got to tell you, some of our therapists didn't have a clue in terms of the realities of what it was like in some of these neighborhoods to try to initiate recovery when you're walking through crack vials ankle deep in and out of your apartment. So once we did that, once we began to get them a sense of that environment, they said, well, they can't recover there, we got to get them out of there, right? And for some of them that might have been a realistic goal, but it's not a realistic goal for every single one of them. Because you know what it kind of said? There's a hidden message here. When we began to do that, we said either we have to find a recovery conducive environment, or we have to create one in that natural world. And pretty soon everybody kept going out and saying, oh man, nobody can recover in that world. Nobody. So we got to send them out to the suburbs. We're going to send them out to go into recovery homes out there where they can see what stable life and good quality recovery looks like. What's the message? If you're an African American, the message was you got to leave your culture and you got to leave your people to be able to enter recovery. I think that's a horrible message. Because it simply ain't true. But they may be right in the sense there ain't any recovery in that 16 square blocks. So the issue becomes, how do we take recovery to that 16 square block? Some of the most dynamic recovery ministries that I've encountered in the past year are ministries that began, where's Jim? Where are you at here? Oh, there you are. I couldn't see you. You can tell my eyesight's bad at this point in my life. That began where they'd had a religious recovery community, if you will, that was sort of facility or institution based. And they began to move out of that and said, we got to move back out of our world into the life of our community. And to do that, they begin saying, we're seeing a significant number of clients in this particular area of a city. Maybe we need to take our ministry to the very heart of that community And so what they began doing was going in and working with the city to buy up condemned houses. And guess what? When crack houses get condemned, the police get to own them, right? So guess what? They went and said, will you transfer ownership of these facilities that have been drug houses and let us turn them into recovery homes? So what do you think happens over time? I mean, those early pioneers, I mean, these are rough days, I'm telling you. You were talking about pioneers, the people who will take the first 12 to 18 months to go in to launch these ministries. These are my heroes. But once they get that thing percolating, what do you think happens block by block? I mean, you can virtually transform a drug-infested community where we're actually talking about the community is now recovering, right? And people are coming out of the community and offering ways they can support this process. Now, when somebody's addicted inside that community, the issue is not we need to take them out of the community, but what? I mean, because the big question is not how do I get them from their world to my world? I mean, the ultimate issue is how do I nest the process of recovery in that environment? And if that environment is so toxic, then we need a broader community strategy to change and help that community recover. So what do we do? Locus of service delivery, we begin to talk about a lot more home-based, neighborhood-based, community-based services. A lot of people won't come see us in a specialized addiction. I'm not just talking about this in terms of communities, poor communities of color in particular, where we would work with local neighborhood community organizations. I'm talking about doing this in some of the most affluent communities in Atlanta. And you know what? You can't do that with an addiction-specific agency because the stigma is such they won't come. So how are you going to do it? You're going to infiltrate. Everybody hear me? You're going to infiltrate. You're going to say, how do we nest? Where can we find and begin to build pockets of recovery inside institutions that are not stigmatized? So if we got a women's health clinic, guess what we're going to do? We're going to offer a half-time staff person to work and provide recovery support services and education for women who come through that clinic. Where else? Churches. Recreational facilities. Yeah, here's an interesting one. Let's talk about people who had some influence and power and have lost it in the past 12 to 18 months. Do you understand? I mean, they've lost their houses. They're about to lose their houses. They're in traditionally affluent communities. They got a whole lot of signs of social distress rising in their families, including alcohol and drug use, which seems to be the one thing that they're not cutting out of their budget. Right? And it's kind of classic self-medication in times of social distress. Where would we find those people? We're going to offer to run a group on managing stress during times of difficult change. We're going to offer that to community clubs, community organizations, and through the auspices of managing stress, we're going to come in and begin to talk about what happens to people around their alcohol and drug usage during times of high stress. If I did a community announcement that said we're going to talk about stress and distress in families, I might get 50 people show up. If I say in this same community, we're going to talk about alcohol and drug problems in families. In these kind of communities, it's going to be a lonely night for those of you who are staffing it. Again, question, not how do we get them to us, how do we nest recovery or create alternatives? Remember my reference to Don Coyas this morning? Remember our tree we dug up and brought back to life and stuck it back in that same old dirty hole? Don says we need a healing forest. The issue is not saving a tree. He said, he says in the native way, there is no separation between the individual, family, tribe, and community. To heal one is to heal all. To wound one is to heal all, or is to wound all. So what he's saying is what? You got to treat the community. You got to treat the soil. And you got to treat the soil, meaning you got to treat the conditions out of which these rising alcohol and drug problems are getting fed. Does that mean that there's an advocacy role in all of this? This drug-saturated community that I'm talking back here about us taking over. What do you think the alcohol advertising is in this community? What about the frequency of alcohol outlets? If I did a mapping and looked at how many alcohol serving establishments exist in this 16 or 18 square block area of this community. What do you think we'd find in terms of high alcohol content alcohol products in this community as compared to almost any place else in the city? Does that mean that we begin to confront the alcohol industry and distributors related to their marketing and they're pumping high purity, high potency alcohol products into our community, and then using young African American athletes as an example to market those products to our children? Yeah. It says we start raising hell about that and say we're not going to be silent about those conditions in our community. And that's part of what Don talks about in terms of healing forest. Big issue, number 7. One of the best predictors of treatment outcome is service dose. Notice I did not say length of stay. This is not about, oh great, Bill's arguing for more days of inpatient treatment. I've run a lot of residential inpatient treatment programs in my life, and I'm not here to make that argument because the evidence doesn't support that. The evidence supports a dose effect for non-methadone treatment modalities, a minimum dose, as we heard at break this morning, of 90 days. That's not within I'm not saying you need to keep people 90 days in your level of care. What am I saying? This can be across multiple levels of care. What we know, when we get to 90 days, above that, recovery outcomes begin to increase. When we go below the 90 days, recovery outcomes begin to deteriorate. Now let's switch for a moment and talk about methadone. There, when we have a dose less than 1 year, I got a new study that's talking 2 years, so I'm kind of got this piece, I'm just giving you on probation. 1 year pending a new study that I got to look at. But up until this study, what we would have said is with anything less than 1 year of methadone will generate exceptionally high relapse rates the second you stop methadone, and also increase morbidity and mortality. Because what? People have lost tolerance through the process of methadone detoxification. And when they go back and resume use, what's the risk of overdose deaths in that population? Very high. So we not only get high relapse rates, we get high risk of, in that process of relapse, we get high death rates from overdose. So the issue is not how quickly can we get somebody out of methadone treatment. For those of us who have anti-methadone biases, the science says what? We need to keep people in methadone for a long enough dose that we can bring a level of stability to their life and begin to build a large amount of recovery supports around them before we begin to talk about the process of titrating, tapering, or full detoxification. We referenced that this comes out of NIDA's Principles of Addiction Treatment. The 90-day just keeps coming up again and again and again in all of our studies. So here's the question. In your state, I know we got 3 or 4 states represented here today. In your state, what percentage of clients from the point of admission to the ending this service episode do you think get 90 days across levels of care? You know, I wish I could tell you, but I can't tell you. You know why? Everywhere I go, people can tell me, we can tell you the average length of time in residential. We can tell you the average length of time in outpatient or IOP. But guess what? Our data systems right now are not even sophisticated enough to tell me if a client goes from detox to residential to IOP to outpatient and discharge. They can't link the same identity together and tell me what percentage of those clients end up with more than 90 days. So we don't have the data. But when we do these little spot checks, what do you think we find in most states? Percentage of clients who, if they're admitted to, and I'm talking about without service breaks. I'm not saying they do residential, go out and relapse, and 2 weeks later they're back in another, that's a new admission. The clock starts all over. They can go from multiple levels, but there's got to be continuity of care. That's the 90-day dose. What percentage? Looks like less than half. Less than half, almost across the board, nationally. Less than half. Let me use another chronic disease analogy or acute disease. We all know about antibiotics, right? Because we all had, most of us in this room have had antibiotics. And you know the great news when you take antibiotics is about a third to halfway through them, your symptoms are gone. And a whole bunch of people stop taking them, right? And you know what? That's the great news. The good news is for some of you, that will be enough to take care of that thing. You can leave them in your cabinet and you'll have half left for next time, right? Like I know a lot of you people do that because they're getting expensive. But let's go. Why is it so important to take all the antibiotics? There's a bunch of reasons here. Because when you only get half the antibiotics, there's an incredibly high risk of the condition returning because of inadequate dose. And it's not just that it returns. It returns in a more virulent form, and now you're resistant to the treatment because the bugs figured out how to fight that half dose you gave them. And it won't work anymore. Do you think we got some treatment-resistant folks out there because they've been cycled through so many brief treatments in the United States? Yeah, I think we do. I think we do. Majority of people completing addiction treatment resume alcohol and drug use in the next 12 months. Of those people who do that in 12 months, most of them will do that in the first 90 days. Of those who return to alcohol and drug use in the first 90 days, listen to this figure. Of all the people who relapse, all the people who will ever relapse following an episode of addiction treatment, called an index episode. So if I take 100 people or 1,000 people and we take this admission and we study all those people who will ever relapse after their discharge from this one episode of treatment, and we look at all of those who relapsed, between 80% and sometimes even as high as 90% of those will do so in the first 90 days. Is that an amazing figure? Did everybody hear what I just said? Of all the people who will ever relapse, when you tell them goodbye, 80% will do so in the first 90 days. Now, if there was any other medical condition that we knew the time of greatest vulnerability for relapse and reoccurrence of that condition was in the first 90 days, how aggressive do you think we'd be monitoring it? Absolutely. I mean, we would be there with them, right? I mean, we're going to be checking on them and checking on them. Yeah, this number 90 keeps coming up. We've got this sophisticated research. We spent $1 billion to tell you what an AA old-timer would tell you with a 5th grade education. 90 days. What's this tell us? I want you to think about tomorrow. We're going to talk about shrinking resources tomorrow. If you got little resources to apply to redesigning what you do, and you got a little bit of resource to apply here in terms of post-treatment monitoring and support, when do you want to saturate those resources? Right here. What's it tell you? From the normal time we disengage and tell people goodbye, and by the way, try to get back for a continuing care group, start the clock ticking and saturate those 90 days. Okay, for our adolescents, this is the Cannabis Youth Treatment Study. 600 adolescents randomly assigned to the best outpatient treatment this country has to offer. This is 1-year follow-up data. If we want continuous, uninterrupted sobriety, that is the green piece of the pie. Of 600 adolescents, we have 12 adolescents, a little less than that actually, that have maintained continuous, uninterrupted sobriety. 40%, we have no measurable effects of the intervention. Meaning that post-treatment drug use is no different than pre-treatment drug use. But look at these other groups. So about half, by the way, if we think treatment works or doesn't work, we got about half. Now, this group here are in and out of recovery, in and out of problems, but they're spending more time experiencing problems than they are in stable recovery in the first 12 months. This next pie up is intermittent, 7%, but they're actually spending considerable time in recovery during that first year. The next group is later sustained recovery. This is a fascinating group. This is a group that clinically deteriorated almost immediately after treatment. I mean, they were high within minutes of discharge in some cases. And we thought, oh man, broke our hearts. Treatment failures. So the early outcomes looked horrible. But when we got out to 3 months and 6 months, and particularly 9 months and 12 months, what do you think we found? Nice recovery effects. This is a typical adolescent recovery pattern, not unusual at all. Because I don't care what we taught the adolescent, cognitively, how do they learn? They learn behaviorally. And we have given them a set of knowledge that principles they now have to test out. And if their experience confirms what we shared with them, what happens? As the consequences reoccur, right? They kind of get these aha moments and personalize that and then migrate back into long-term recovery. Yeah, this is David's raising this question. Yeah, David's raising this question. First, was this an effect of treatment, or is part of this 9% kids who were lower problem severity who would have got well on their own? I mean, that's a possibility. And we don't know that, but here's what we do know. We tried 5 different therapies. 600 kids were randomized to these different outpatient therapies. We found effects in all of them, meaning the kids who got treatment did better than some control group kids who didn't get treatment. But when we compared the individual treatments, like with Project Match, what do you think we found? Almost no differences. Almost no differences. So, my point is, in our adult and adolescent studies, if we followed your program, I would predict this. We will find people who are your superstars. Sustained, uninterrupted recovery from the day they were discharged from your program. And we ought to celebrate those. Those people do well and have transformed their lives. And we are thankful for that. We have people who have no measurable effect. We come out, I'm laying it out for you, we simply can't find an effect of the treatment you gave them compared to pre-treatment. Early suppression followed by clinical deterioration. Meaning we get a kind of honeymoon period of recovery, and then they fall off the cliff. And we ain't around, right? And we're gone. We already hugged them. We already had graduation ceremony. That's the last time we saw them. And they're going unchecked. And by the way, now they're going to relapse. The problems are going to begin to escalate. We're going to get clinical deterioration. They're going to burn up all their recovery capital over a period of weeks or months. And then when will we see them? Tipping point, right? We get back to that final crisis that then brings them back to us, and then we start treatment all over again. That's the traditional cycle. We get early deterioration, bounce back, again, good recovery, and then we get cycles of in and out. People are in recovery, then they're addicted, they're in recovery, they're addicted. Are you okay with the idea of people binging on recovery? Think about it for a minute. Think with me for a minute. When they hit a wall, they're getting back in the program, they're doing meetings twice a day, calling their sponsor 3 times a day, being a total pain in the you-know-what, and they're getting it. And then they relapse, and then they disappear. And they're in, out, in and out, and I can't tell you where they're at. Because at the end of 12 months, what? Recovery's not stable. But let me tell you the good news. Is addiction isn't stable anymore either. Because what do we got? We got constant. Yeah, we've broken the cycle. We got constant help-seeking behavior now. But we still don't know for sure which direction it's going to go. Individuals leaving addiction recovery are fragilely balanced. I want to make this point. In a traditional acute care model, decisions related to how the scales are going to tip are being made in a world in which we are not present. Everybody with me? We are not there in their lives. Other people are there in their lives. Other people are doing post-treatment monitoring and checkups. Drug dealers do post-treatment monitoring and early reintervention. People this kid got high with are doing post-treatment interventions. Agreed? Think of all the things from the life that are going to come back and invite this person back in. People come up and hand people rocks to celebrate getting out of treatment, right? If they're going to have a fair chance, what do they need? We got to be there. We got to be there. We got to put forces in their world that can compete and maybe have those scales tip towards recovery rather than re-addiction. Oh, let me do this. Let me tell you how unstable recovery is. This is a sample. I think this was around 1,300 clients in Chicago. We studied them over 3 years. We studied them every quarter. And all we wanted to know every quarter was one of 4 things. You are in stable recovery for this quarter, you're incarcerated, you're back in treatment, or you're in the community but using. That's all we did. All we wanted to know is your status. And then we wanted to know how stable is the status of each of these quarter after quarter. What do you think we found? What do you see with all the lines? The lines are people moving from one status to another. More than 80% of the people in the study over 3 years will change status. Which says what? Recovery is not stable, but in the community using is also not stable. So we got people what? Constantly moving in and out of these. And by the way, this is a natural study. We're not intervening. We're not doing. All we're doing is just checking on people to study these cycles. What is important is in individuals with this pattern, if we look at the pathway to treatment or to recovery, most individuals who end up in recovery do so through the vehicle of treatment. So that's how we check, David. Are we getting like a placebo effect, or are we getting, kind of a natural recovery effect that we're attributing to treatment? And no, it appears treatment specifically helps stabilize that pattern. The summary that we gave you this morning from the charts, most people, and I want to emphasize, who achieve stable recovery from substance dependence. I'm not talking about abuse now. Everybody hear me clearly. I'm talking about dependence, alcohol and drug dependence. Who achieves most, meaning over half, who achieve stable recovery, will do so after multiple years, multiple efforts. Remember what we said this morning, the average was 9 years, 3 to 4 episodes. In the one sample we did of 1,200 people. By the way, if we studied nicotine addiction and efforts to stop smoking, what do you think we'd find? We're going to find that same thing. In fact, we're going to find relapse rates that are about the highest of all the addictions when we look at nicotine. Durability. What did we say this morning? I want to reinforce this. What's the stability point? 4 to 5 years for alcohol, and what we say for opiates, it may be even less stable. Remember, we got a 25% relapse rate at 5 years, who will eventually go back to active narcotic addiction. Fragility of family. I want to again reinforce this theme from earlier about the instability of family life at this point and the need to monitor family. Okay, here's the data from the research. Good news. Post-discharge continuing care. How many of you have some kind of continued care program? Great news, because participation in these can dramatically enhance long-term recovery outcomes. You all knew that anyway. Here's the bad news. Only about 1 in 5 adults, only about 36% of adolescents will get any dose of continuing care following discharge from primary treatment, meaning residential, inpatient, IOP, outpatient. Very, very low. Right now, I want you to look at, of the people coming into addiction treatment in the United States, what percentage have been there before? 64%. 64% of clients have already been there. Look at the next numbers, because they're scary. 23% are accessing treatment for the second time, 20 for the third or fourth. We're almost at 20% of our clients who've had 5 or more prior treatment episodes. What's this sound like to you? I thought we were designed to stop the revolving door of the jails and the hospitals. Looks like we've become that, doesn't it? You know, some of you said amen this morning when I said we're putting people through multiple episodes of stabilization with no measurable long-term recovery outcomes. There's the data, isn't it? 20%, multiply cycled through. Let's talk about in a recovery management model. Can we first off just acknowledge that continuing care in the current acute care design is truly an afterthought in virtually almost all programs I've studied. And some of you may say, we got a good continuing care program. That's good. I'm delighted to hear that. Because when I come visit you, I want to look at your budget. I want you to tell me the percentage of the budget of the agency that's devoted to post-treatment continuing care. And I want you to tell me how many FTEs you've exclusively devoted to post-treatment monitoring and support. And what do you think we'll find? I'm not personally blaming you, because in an acute care model, we have a system that doesn't pay for post-treatment monitoring, support, and continuing care. Agreed? So we simply don't have it. So how would this be different? In recovery management, we use this language. When we talk about assertive continuing care, we're talking about post-treatment monitoring and support, meaning we're checking on people, and while we're checking, we're supporting them. We're doing stage-appropriate recovery education and coaching. Meaning what? Stage-appropriate recovery education and coaching. Are there some very predictable early recovery questions for people recovering from methamphetamine or cocaine dependence? Related issues related to food and diet and sleep and teeth, and I could go on and on with this list. Yes. So what do they need to know? Rather than give them all the lectures about the disease of methamphetamine use, we got to say, what's normal recovery like? When are my sleep patterns going to get back together? When am I going to gain weight? And how do I gain weight? And what do I do with these nasty teeth in my mouth? You got some key questions. We know when those questions arise. And we got a world of collective recovery experience to guide that person through those. That's what we mean when we talk about this kind of recovery coaching. Assertive linkage to communities of recovery. I didn't say passive. Passive linkage to communities of recovery is, that's the good news is participation in recovery communities can dramatically elevate long-term recovery outcomes. Good news. Good news. When people are assertively linked to those communities, affiliation and participation rates significantly increase. The bad news, most people in addiction treatment programs are passively linked to these communities, meaning they are verbally encouraged to go and at best handed a meeting list. We have studies where we've encouraged people verbally to go and given them a meeting list, described even transportation, how to get to those meetings, and we came back later, nobody got there. I mean, we've had 0 participation rates related to the effectiveness of passive linkage. When we talk about assertive linkage, what are we talking about? Taking them there, linking them to not to a particular meeting, to a particular person. Let's come back and talk about our women again, can we? If we got women with these chronic self-defeating styles of these loser relationships, long predatory histories of picking men, aggressive, violent, are there some meetings we want to keep them as far away from as possible? We got to tell the truth sometimes. Some group consciences are stronger than others, right? Some groups focus on 12 and some focus on 13, right? There's another way to put it. So my point is, if we're doing assertive linkage of women coming out of these programs we were discussing at break, are there specific meetings we want to get them in to assure their physical and psychological safety and the lack of diversions? Yeah, absolutely. That's assertive linkage. If and when needed, early reintervention and relinkage to treatment and recovery support groups. When we are in their lives and use returns, what level of problem severity are they at? Yeah, it just started again, right? They may even back into the early honeymoon period, but they're kind of panicked around it. So we've got low problem severity. What did I tell you about low problem severity? We got good prognosis. When people just got a little bit of a problem, we got a great prognosis for that. And guess what? They still got a lot of recovery capital they built up through treatment and early recovery. They got people around them, right? They got social credit. People started believing in them again, offering help and support to them. If we re-intervene now, the prospects of restabilization are great, as opposed to waiting for 4 months until they've destroyed all of that and now they're back in crisis. The focus is not on a service episode, but managing the course of the disorder over time. Let me tell you how different this is. I want to contrast recovery management, assertive continuing care, from continuing care as usual in the United States. Number one, first off, most of you are going to do continuing care for your graduates, agree? You got to successfully graduate from treatment to participate in continuing care. Yeah, I do too. But in the acute care model, that's what we do. We graduate people. It's done. So what do we want to do if we're talking about long-term recovery management? Get rid of this word. What the hell is graduation in the context of a chronic lifelong illness that's going to need active management? Yes. Can you speak very clearly? Go ahead, try. Yeah, no, I can summarize your question around how long should somebody stay in aftercare. First off, I want to say we need to eliminate that word forever. Because aftercare suggests what? You had the really good stuff, the important stuff. And now we just need to make sure we maintain our good work so you don't screw it up. That's aftercare. In a chronic care model, there is no aftercare. All care becomes continuing care in the context of management of a chronic disorder. So we're going to talk about continuing care, and if we answer that question, the question is going to be, we need to stay involved in their lives until they can individually or with family resource manage this on their own. So with some chronic disorders, that may be they may get this very stabilized, and they may need no specialized help and can monitor it through their primary care physician. In the addiction world, what did I tell you about stability? 5 years. Now, let me hear you. I don't want you going back and said, Bill said we should fund 5 years of treatment. Because I ain't talking about treatment. Everybody hear me? I'm not talking about 5 years of primary treatment. God forbid. What am I talking about? 5 years of low-intensity monitoring, support, education, and the potential when needed for reintervention back into primary care only when it's needed. And when you use that model, by the way, when people need restabilization, it generally requires very, very short periods of stabilization. We're not talking about running people back through cycles of 30 or 60 days of inpatient treatment. What did I tell you earlier? They know how to initiate recovery. That's not the issue. The issue is to come back, how do we identify the difficulty around recovery maintenance and move them back into that world as quickly as possible with supports to do that. Number two, the responsibility for contact. If David and I are running aftercare groups 2 nights a week at our agency, and people can randomly come to whichever group they want. And I come to David and I said, has Bernie been in your group the last few weeks? And he'd say, no, I haven't seen Bernie. I ain't seen him in mine. And David and I sit and mourn the loss of poor Bernie. Ain't neither one of us picking up a telephone. We're not making plans to go get Bernie because what? That would be codependent on us, right? That would mean we might need some treatment ourselves if we got involved in that kind of rescue work. I mean, that has been the attitude, has it not? That's the old world. In the new world, guess what's going to happen? It ain't going to be a casual. We're already knowing we lost Bernie. I mean, the second we got a red flag that comes up that says Bernie lost the second meeting without communicating with anybody, we're there. I mean, we're calling cell phone, we're calling home, we're calling his Bernie's mama, we're calling his lover, we're calling whoever we can get, tracking Bernie down. And push comes to shove, he and I'll get in the car and we'll go see if we can find Bernie. That's a very different kind of monitoring, agree? Old style, that's what we're talking about. 3, timing. What did I tell you? 90 days. So we want to saturate, if we're going to schedule contact of support. Do we have some people that need a call twice a day the first 5 days they're out of treatment? And don't tell me, well, they can't because they ain't got no phone. They all got cell phones. Ain't no drug addict worth their salt that ain't got a cell phone. Don't tell me that. I ain't saying they're legal, but they got cell phones. Okay, intensity. Can we not only focus on that first window, and as they do well, we begin to titrate down the contact. We go from daily to twice a week to once a week, right? But we're constant, checking in and encouraging and coaching and praising. And then we go to twice a month and once a month. And then we call on that once a month call, and Bernie sounds like hell today. Flat affect. How'd you sleep last night? Haven't slept. And what are we getting? We're getting all these ugly signs. Sound like vegetative depression. No appetite. Haven't used, but I've been thinking a lot about using. What do we got to do? We're calling at noon. I want to talk to Bernie about what he can do in the next 2 hours to feel better. Because I'm calling him in 2 hours to check on whether those things worked. And if not, we're going to keep working. We're going to keep problem solving that day. And by the way, Bernie, is it okay if maybe I'm worried about you? Can I check on you? Can I give you a call tomorrow morning? And what am I doing? I was now decreasing contact, and now in this period of crisis, I'm dramatically escalating the intensity of that. And as soon as he restabilizes, guess what I'm going to do? Praise, encourage, it's going to go back down over time. But I also know, and part of that's that 90 days. I got to get him through that 90-day window of vulnerability. Can any client also tell you times to put on the calendar that they're going to need some extra support? I'm serious. Know thyself. Look at your life the past 5 years, and you tell me, in the next 6 months, what are the dates I should mark on the calendar that I should be calling you? And we should be trying to get together maybe even. And you know what they're going to talk about? Man, 4th of July with my family. I ain't got through one of them sober ever. So we need to do something around the 4th of July. I know I'm going to be vulnerable anytime I either start a new relationship or I break up in a relationship. Some people are very fond of particular dates. You know, the anniversary of their 4th or 5th divorce that was very special to them, right? May be hard to get through. I don't care what it is, but they can tell you that. So we make that part of the schedule. Recovery. When we go from the treatment plan to the recovery plan, what we're going to begin to do is almost as part of the recovery plan, the client's going to tell us, we're not telling the client what he needs to do with continuing care. He's telling us what he needs by way of support in the coming months. Now, what we generally say is the first 90 days is automatic. And beyond that, let's talk. And we're going to put a schedule together, and they're going to request when they want us. Number 5, duration. What we say, continuity of contact over time with the primary recovery support specialist, preferably the same person when that's possible. Now, having said that, I need to tell you the Achilles heel in this entire model is right here. Tell me what staff turnover is in addiction treatment in the United States. Now, I want you to think, some of you have been blessed because some of you got chronic disorders, like me. I got a couple of them. And I've been very blessed to have the same physicians, and they monitor me all the time. I got to do blood count checks like more than I even want to think about. Same people with me all the time. And some of you got primary care physicians that have taken you through long, long courses of keeping some of this stuff stable. That's the ideal model. But in our world, with the turnover of addiction treatment, we can't guarantee that, can we? What we're hoping is that we're going to be able to develop a stable of recovery coaches, that the quality of satisfaction in their work will be high enough to dramatically lower the turnover in those roles. And you know what? We got it right now. Because in a lot of the places that we're beginning to implement these, the recovery rate for addiction counselors is twice as high as that we're seeing with recovery coaches. So we're hoping we will, to the greatest extent possible, we're going to be able to do that continuity. I think at a practical level, some of this we're going to have to do in teams to be able to assure continuity of contact over an extended period of time. Location, community-based versus clinic-based, meaning we're really talking about, rather than inviting people back for continuing care, we're talking about how do we get a presence in their life. What do you think the most underutilized post-treatment recovery contact for adolescents is right now, today? You said it. Who said it? Texting. Texting. How important are cell phones in the lives of adolescents in the United States right now? If you want to, how viable would online recovery support groups be? And monitoring systems that also integrate text messaging as part of the encouragement and support process. We need to, that's what we're talking about, is rather than saying, invite all the adolescents to come back for group today, the question is how do we take ourselves and inject them in the lives of those adolescents where they're at to encourage recovery stability. Staffing can be provided by professionals or it can be done in a peer-based volunteer format. Technology, increased use of telephone and internet. Okay. Oh, do I want to go through all these studies? All I can tell you is we're rigorously doing all kinds of studies about recovery checkups, and I don't have much time, so I'm just going to tell you we're getting significant outcomes. If you want to lower post-treatment relapse, develop systematic schedules of post-treatment recovery checkups. Even if you're not going to do the aggressive kind of monitoring that I talk about. I mean, think about it. What we're getting significant effects on quarterly telephone-based and interview-based, face-to-face interview-based checkups. Now, we need to think about, we're violating my first principle, which is what? Saturate support in the first 90 days. So at the end of the 90 days when we call, where are we at? We're at the end of the period they needed the greatest amount of support. And we're still getting effects just from doing that. What do you think it would be if we aggressively did the early and then titrated that down to quarterly, or in some cases as we get out to 4 and 5 years, maybe an annual checkup? Oh, let's go to number 8, relationships with recovery communities. Let's look at this. Historically, we've said we have a continuing care program. It's called 12-step recovery fellowships for a lot of treatment programs in the United States. We've simply passed the torch. They will do our continuing care for us. And that's okay. I mean, you can take that position. Here's a problem with it. Affiliation rates, we get very high attrition in the transition from participation during treatment to initiation of participation following discharge. Are you with me? That initial handoff in the community. Then the second thing is, of all those who start AA or NA or WFS or LSR participation, how many will still be participating at the end of year 1? We're going to lose about 40%. So from the standpoint of relying on any recovery fellowship, what did I tell you earlier for recovery fellowships? It's like treatment. You're going to have optimum responders, partial responders, non-responders. You may even have some people that get screwed up, and we got a bad mismatch with some of them.
get a signal to increase the bail. You know, I can buy a signal to increase the bail. So you really never know if they're actually going to do it.
Yeah. The question here was validation. How do we know? How do we check self-reports related to recovery mutual aid participation? Well, yeah, I would agree with you. I'll guarantee you, if you're in one of my communities, and you're telling me you've been to a particular meeting that we agreed was the one for you to go to, in a matter of 5 minutes, we can have some conversation about what happened at that meeting, and I'll tell you whether you were really at that meeting or not. Okay? And that's why. But this is not a clinic. This is not a professional clinical role. That's why I need expertise of somebody who knows that recovery community backwards and forwards to be able to do that. David, go ahead.
No, she hasn't.
Okay. We don't know. All we know is when we interview people who were participating in the first 30 days that were not participating at 12 months. So, and what we know is we've lost 40% participation. And these aren't studies of mutual aid. These are really post-treatment outcome studies that we're doing in terms of our asking. Okay, let's look at this. We talked about active versus passive, mutual aid, RN model, pathways and styles. Let me give you one difference. I've talked about peer-based supports. If we said, one of the things I want you to take from me today is this thing. There are multiple pathways of recovery and all are cause for celebration, right? If that's true, and we're hiring recovery coaches, and we're implementing a philosophy of choice with people, right? So everybody doesn't have to recover the way I did as a recovery coach, right? Then what that means as a recovery coach is simply knowing my pathway of recovery is not necessarily a credential to work as a recovery coach. Are you with me? That I may be an AA or I may be an NA or another 12-step fellowship, but to work as a recovery coach in this model means I need to be fluent across recovery pathways. I may be able to quote the big book to one client and quote the Bible to the next client and quote the Quran to the next client. Are you with me? In other words, I got to have the ability to work across recovery pathways as opposed to within one framework of recovery. That's very different than a traditional sponsor role, agree? Who's going to work within one framework of recovery and simply needs expertise and knowledge in that. Number 9, relationship model. The traditional model, recovery is based on relationships that are hierarchical, time-limited, transient, and commercialized. Anybody want to argue that? We base the addiction counselor role on the role of physician, psychiatrist, psychologist, social worker. Talked about therapeutic boundaries, high degrees of power differential, et cetera, et cetera. And those are very appropriate for professional relationships. But and particularly for acute disorders, if I break my ankle in Atlanta while I'm here, I hope somebody's going to get me to an emergency room. I hope the physician that takes care of me there is going to do a good job setting my ankle so I can get back on an airplane and get myself back to Florida. But you know what? If that physician, if he or she is still calling me 5 and 6 months down the road, I'm going to file charges against them. They got no business in my life. That's an acute problem. Fix it and let me get on, and I do not necessarily want you in my life. But if this is a chronic disorder, what? Do you understand? So what I'm saying is we based addiction counseling on the acute emergency room model. But if this is in fact a long-term partnership, remember what we said this morning? If David is now emailing me afterwards and checking on phones now, in the acute care model, he gets disciplined or fired for boundary violations. In the new world, we say, great job for hanging in with this tough client and staying in contact and staying engaged. Very different world, agree?
Are you saying we're including a chronic disease in the acute care model?
Yeah, that's exactly what I'm saying. You got it. Number 10, evaluation. The way we've traditionally evaluated addiction treatment programs is one episode at a time. So if a client has been through 5 episodes, immediately began using again following discharge from the first 4, we say the first 4 were failures, they had no effect because they didn't alter the course or trajectory of the disorder. And the 5th one was a raging success because we now seem to have stable recovery. Except what? The first 4 may not have been failures. The 5th one may not have been a success. The 5th one may have been tipping point unrelated to the treatment episode. The first 4 may have played incredibly important roles in shortening addiction career and extending recovery career. Let me tell you where we're going with recovery management. I mean, this is the heart of it. What we're looking for, my vision in recovery management, is to find for each client what the AIDS cocktail was. Do you understand what was the innovation there? We had these multiple medications, all of which had gone through clinical trials, and to be blunt, what? Had no effect altering the course of AIDS. But we suddenly found when we combined and sequenced these things together, what happened? I mean, we transformed the entire history of AIDS because we had these dramatically elevated effects of these drugs used in combination. What we're talking about in recovery management is how do we combine and sequence clinical and recovery support services to dramatically elevate long-term recovery outcomes. We're looking for that kind of synergy. So in terms of the 5 treatments, we're not going to mourn the fact that this person had 5 treatments. What I may mourn is the 5 treatments occurred over 12 years, and maybe, what if we could have cut those 12 admissions, spread them over 6 years, and cut an addiction career by half? What do you think it'd mean for this individual's life, in the community's life? What would it mean for the social cost involved? That's what we're trying to do, is we're looking at people with very severe, very complex problems. How do we shorten the addiction career by hanging in over multiple interventions to contain that, and then extend, stabilize, and enhance the quality of long-term recovery? And so we're going to begin to look more at service sequences and combinations, and which have dramatically elevated recovery outcomes, as opposed to looking at each one in isolation. Closing thoughts, 4 of them. Recovery-oriented systems of care, which we're going to focus on completely tomorrow, and recovery management, which is, again, ROSC is the big organizing framework. RM is a philosophy of treatment inside a treatment program. Represent not a refinement of modern addiction treatment, but a fundamental redesign of that treatment. I'm hoping the 10 areas of practice we went through this afternoon, that you would agree, this is not treatment as usual. This is not, we just need to tweak a little bit better what we're currently doing. This is a pretty radical redesign of treatment. Number 2, overselling what an acute care episode of treatment can do risk a cultural backlash against addiction treatment that could threaten the very existence of this field. I absolutely believe that. I got to tell you, 3 years ago, I was asked to write an article about what, as a historian of addiction treatment and recovery, what is the perfect storm that could lead to a collapse of addiction treatment in the United States? I want to talk about a couple of ingredients I wrote in that scenario. I said we are very, very vulnerable at this unique period in history. I said here's what we could have. We could have a virtual avalanche of celebrities moving in and out of rehab to escape the responsibility for their latest indiscretions in ways that totally discredit the reputation and integrity of addiction treatment, followed by a financial crisis of unprecedented proportions that would force state and local policymakers to make decisions of whether we do roads or schools or addiction treatment. And under those circumstances, I said we are vulnerable. We could collapse as a system of care in the same way that addiction treatment collapsed in the first 2 decades of the 20th century. And what have we got? We are very vulnerable right now. We need to tell the truth about addiction treatment and recovery. We need to tell exactly what the recovery rates are and what the relapse rates are to everyone coming into treatment and every family member and to every referral source. But we also need to, at the same time, not only give them that brutal detail, we need to tell them, and here's the good news. Long-term recovery is alive and well in this culture, in the lives of hundreds and thousands of individuals and families. But here's what the recovery process looks like. It's more complex and more time-intensive than what we anticipated it was. We misread that, and as it says in the 10-step, what do we need to do? And when? What do? I'm saying we need to do that inventory, and we need to make our apologies to this culture. That with the very best of intentions, we got some things wrong. And now we have the data to try to restate out what this thing called addiction and recovery are about and really tell the truth about it. And that's, I think, going to be part of our shift. I think if we do that well, we got a chance to get through this. If we maintain our arrogance, running around talking about treatment works, in a world where people are increasingly seeing people for whom treatment didn't work, I think we're very, very vulnerable at this point in time. Number 3, and then we'll go. It will take years to transform addiction treatment from an AC model of intervention to a recovery management model of sustained recovery support. My colleagues tomorrow are going to talk about what it's like in different states and cities to do this. And what I can tell you is every time I think I've got it figured out, I learn again I have underestimated the time, the effort, the enormous complexity, the politics, the egos, the turf, the territory, the budgetary issues, complex policy issues, all kinds of nuanced issues around theories of treatment and recovery. This is tough work. And Ijama Chara is going to describe to you, I think, in remarkable detail tomorrow, what we're beginning to learn about how you plan this at a broad systems level and how you begin to implement this. The great news is we're involved in cities and states that are doing just some stunning things. And on a day-to-day basis, we're overwhelmed. We're calling each other saying we need medication today. We're calling each other overwhelmed and thinking it's insane and chaotic and this is never going to work. And 2 days later, something unfolds in front of us that blows our minds in terms of what's going on inside these communities and how incredibly exciting it is. So we're gonna shift. Today was, why do we need to make this change? I hope you walk out of here believing that. We need to do that, and we need to do it quickly. Secondly, how will treatment change when we make this transition? I hope you got a little bit of clue about that. And if not, then read 400 or 500 pages of what I've written, and that'll help clear up any misunderstanding about it. Tomorrow, we're going to shift from what do we need to do to, okay, how do we do this? How do we fund it? What are the policy implications? On and on and on. Let's shut her down for today, shall we? Take care. God bless. What do we really know about recovery? How many libraries could we fill if we just put the scientific knowledge base of recovery? What do you think the odds are of their recovery in this environment? So, some people said,